third international webinar series on public health in the agenda of Kudus is going to be start. Assalamualaikum warahmatullahi wabarakatuh. Welcome to the national webinar series on public health in the anniversary University Muhammadiyah of Kudus. Singing National of Indonesia Raya. Ladies and gentlemen, please all rise. Ladies and gentlemen, please sit. Praying to Mr. Rizka Himawan, Master of Psychology. The floor is yours.
Assalamualaikum warahmatullahi wabarakatuh. Bismillahirrahmanirrahim. Bismillahirrahmanirrahim. Ya Rabbana lakal karim wa abini sultan. Rabbana la tuzigh qulubana ba'da wa hab lana min ladunka rahmah. Rabbana hab lana min azwajina qurrata a'yun waj'alna lil muttaqina ya good of this us from some of concerning this activity. Bless our minds with the light of your guidance to understand the material by all the speakers. And give us good things to
Nine first Hidayah. Of Mrs. Ika Trisanti. The Student Affairs and Cooperation Master of Health. Participant. Ladies and gentlemen, from college Dr. Center of Ministry of Health and Welfare, Professor Dr. the Dean of Medical City of
will the Head of Research and Community Service Department, Ms. Noor Cholifah. The Honorable the Head of the Department, Mrs. Ika Santi, Master of Health. The Student Affairs and Cooperation Director, Mrs. Nur Aziza. Superintendent Hospital Taiwan International Healthcare Training Center and Department webinar conference. Let's upright the Lord of the words and those will keep jati into him further. Salawat and salam is wasallam. Who follow them in goodness. I am pleased to the Search International series entitled Tuberculosis and Pandemic COVID-19 meeting for case prevention and will the effort COVID-19 which creating a space for together share and is more important on how to of care multi-stakeholders multi-partnership response driven by the human right or as individual and the effect global pandemic COVID-19. Ladies and gentlemen, as we know, Indonesia is one of wide burden TB has been determined of eliminate to TB at 2030. Address including to be reporting and make us have hand in hand people the practitioner introduced to help stop the spread of COVID-19 are all too familiar. Mask wearing, isolation for peers and love as for facing this is a pandemic. We have the power to better understand COVID-19 and protect people by bringing to light the cutting edge science and research in the world. In the world, let's forum the furthest dedicated to ending the surviving caused by lung disease. Ladies and gentlemen, when the University Muhammadiyah Kudus vision in the my campus being global, this international conference is one among many efforts to make this vision come true. And this is the second international conference after we held the first ICOSIT in 2019. I believe that by participating in the international webinar, we are the right place and the right team. I wish you all a very successful webinar. I declare that this conference is official open. Thank you very much for your attention, participant in the webinar international in this morning. And I end in the Assalamualaikum warahmatullahi wabarakatuh.
Now, we come to the main agenda of Third International Webinar Series on Public Health in the agenda of 21st Anniversary University Muhammadiyah of Kudus, entitled Tuberculosis and Pandemic COVID-19. This will be guided by Mr. Ahmad Nur Syafiq, Master of Education, as moderator. The floor is yours.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Alhamdulillahi rabbil alamin. Assalatu wassalamu ala rasulillahi ajma'in amma ba'd. Let's pray to our Lord, our subhanahu wa ta'ala, for his mercies and blessings. And secondly, our deep gratitude, please be upon to our Prophet Muhammad sallallahu alaihi wasallam. Well, ladies and gentlemen, welcome back to the third international webinar series on public health today. It's my honor to be here today. My name is Ahmad Nur Syafiq, and I'll be serving as the moderator for this webinar series. One more time, I'd like to say that this virtual conference is held in the agenda of 21st anniversary of Muhammadiyah University of Kudus, or we call UMKU. Right, before we go to the presentation, I'd like to say once again, I would say thank you to the superintendents of Taiwan International Healthcare Training Center for support this conference. Right, okay. Ladies and gentlemen, as the opening remark from Mr. Rusnoto, a doctor candidate, every single country is now trying to face two global pandemics, tuberculosis and also COVID-19. People with COVID-19 and tuberculosis show similar symptoms such as coughing, fever, and difficulty to breathe. And this will be our topic today, tuberculosis and COVID-19. And together with us now we have 5 expert speakers who will talk about this topic today. And now together with us we have the first presenter. He is Mr. Rector, who's going to be the first rector. But hold on, Mr. Rusnoto, a doctor candidate. Before you give your presentations, let me introduce you first. So Mr. Rusnoto today would like to talk about COVID-19 and pandemic interaction. And before he delivers the presentations, let me introduce him first. So his full name is Rusnoto. So now he is a doctor candidate of public health. And he was born in Jepara, 21st August 1974. And his address is on Mamba RT4 and RW4, Kecamatan Pakis Aji, and then Kabupaten Jepara, Central Java. And now he is a rector of the university. And I think he has so many experiences that I can mention one by one. And about his educational background, so he completes the bachelor degree of public health at Universitas Muhammadiyah Semarang, and then he continued the master degree of epidemiology in Diponegoro University. Right to save our time, so let's go directly to the first presentation delivered by Mr. Rusnoto. Sir, the floor is yours now.
Thank you very much, Mr. Syafiq, moderator. Assalamualaikum warahmatullahi wabarakatuh. Alhamdulillah Rabbil Alamin, amma ba'du. Thank you very much for team, professor and team from Taiwan, collaboration in University Muhammadiyah of Kudus to Edy Internasional, the search series. Thank you very much. I will to present about tuberculosis and underreporting case and situation tuberculosis in Indonesia and COVID in Indonesia. My PowerPoints. Thank you very much. This is international webinar series public health. Series the search, yeah. The slides one, okay. The slides one present in the morning to you looks the PowerPoint. It 2019 WHO WHO Global Tuberculosis Reports. In Indonesia, kita bisa melihat berdasarkan laporan di WHO tahun 2019 about tuberculosis secara global, ada sekitar 200 juta kasus ditemukan dan 30 juta kasus meninggal akibat TB sejak tahun 2020. Kita bisa melihat di dalam grafik yang ada bahwa menunjukkan jumlah kasus TB yang sangat besar, apalagi di tahun 2020 yang TB merupakan komorbid terhadap terjadinya COVID-19, sehingga ini menjadi salah satu tema yang sangat penting untuk kita lakukan satu evaluasi bahwa tuberkulosis merupakan penyakit yang harus segera ditangani karena merupakan komorbid yang banyak menimbulkan kematian. Next, ya. Okay. COVID-19 and TB mortality maps. The higher mortality population live in much of sub-Saharan Africa than COVID-19 in Euro and the US. Kita bisa melihat bahwa kalau kita lihat sebelah kiri, red color, itu menunjukkan gambaran bahwa angka kematian disebabkan oleh COVID terkonfirmasi per 1 juta pada tanggal 4 Juni 2020. Sedangkan di sebelah kanan kita bisa melihat warna merah, kematian disebabkan oleh TB per 100.000 orang pada tahun 2017. Hal ini menunjukkan bahwa untuk TB tingkat kematian terbesar adalah di Afrika selama COVID-19 dan pada dan di Eropa dan di Amerika ini kasusnya juga sangat tinggi terkait dengan COVID-19. Next. Kita coba melihat global underreporting case of tuberculosis. Coba naik lagi. Next lagi. Next, the global underreporting. Yeah. Next, ya, next lagi. Mungkin tidak masuk di situ. Global underreporting case of tuberculosis in Indonesia. Menurut data WHO tentang TB secara global, terdapat 3-5 dari 10 kasus ini tidak terlaporkan, atau kurang lebih adalah 30-35%. Kasus TB di dunia itu tidak terlaporkan di sistem informasi TB terpadu atau terpadu TB. Hal ini menunjukkan banyaknya kasus TB yang ada di masyarakat yang tidak ditangani secara baik, dan ini memiliki potensi yang sangat besar untuk terjadinya penularan TB yang merupakan komorbid dari COVID-19. Ya. Jadi ini satu gambaran. Next, ya, tuberculosis trend in Indonesia about underreporting case. Ya, kalau kita lihat, coba ambilkan yang underreported. Yang gambarnya diagram. Yang diagram. Next. Di atas. Ya. Baik ya. Jadi tuberculosis trend in Indonesia, there are 44% underreporting case. Sedangkan di Indonesia coba kita lihat kasus yang tidak terdeteksi ada 30% atau sekitar 710.000 dan 44% kasus TB tidak terlaporkan. Ada sekitar 401.130% ya. Ini menunjukkan tingginya angka tidak terlaporkan oleh sistem dan ini tidak ditangani secara baik. Hal ini berakibat bahwa kasus-kasus TB yang ada di masyarakat akan terjadi penyebaran yang sangat besar dan ini tidak dilayani secara baik. Ya. The next, tidak apa-apa, Mas. Next. Mas Sandi, lanjut aja. Terus, lanjut aja. Terus, ya, kita bisa melihat BCK efikasi sistem review. Kita bisa melihat adanya dari studi kasus kontrol atau case control study, ada sekitar 77% risiko terjadinya TB. Kita melihat di di penelitiannya Makatani di Dinas Kesehatan 2014 menyatakan bahwa vaksin BCG bisa digunakan untuk penanganan kasus TB, tetapi belum terbukti secara baik untuk penanganan kasus COVID-19. Artinya jika TB ini ditangani secara baik, belum tentu COVID ini akan berkurang dari sisi vaksin. Next. Ya. Kita lihat di dalam BCG vaksin may also have non-specific immunologic effect to mitigate COVID-19. Bisa kita lihat bahwa vaksin BCG memungkinkan mungkin memiliki efek secara imunologi tidak spesifik terhadap COVID-19. Jadi punya efek tetapi mungkin tidak spesifik. COVID-19 adalah kasus yang luar biasa yang memiliki daya serang yang tinggi. Next. Ada penelitian next. Naik lagi. Ya. Satu penelitian non-specific BCG effect, epidemiologic studies and systematic review. Ada dua penelitian ya, there are two research yang mendukung tentang vaksin BCG terhadap efek non-spesifik imunologi yang berhubungan dengan infeksi saluran nafas. Dalam hal ini adalah COVID-19. Kita bisa melakukan dengan melakukan systematic review. Next. Ya. Di prestasi berikut kita bisa lihat evidence specific to COVID-19. Bagaimana BCG memiliki sebuah efektivitas terhadap TB maupun terhadap kasus COVID-19. Kita bisa melihat bahwa BCG memiliki efektif terhadap tuberkulosis, tetapi terhadap COVID tidak begitu efektif. Next. Kita juga bisa melihat di dalam tampilan ini bahwa cell host and microbe BCG vaccination protect against experimental viral infection in humans through the introduction of cytokines associated with training immunity. Di sini kita bisa melihat bahwa di gambar yang atas itu tidak dilakukan vaksin, no vaksin. Dia memiliki virus yellow fever lebih banyak. Kita bisa melihat yang berwarna kuning-kuning keemasan ya. Dia memiliki jumlah lebih banyak, sedangkan orang yang dilakukan vaksin dia memiliki lebih sedikit. Hari ini menunjukkan bahwa orang dengan TB tetap efektif diberikan vaksin BCG. Next. Ya. Consider BCG vaccine to reduce the impact of COVID-19. Dari research of for Nickel Curtis and all, sehingga kita dapat melihat bagaimana vaksin ini memiliki sebuah efek terhadap COVID maupun terhadap tuberkulosis. Yang pertama, BCG vaccine is already in the short supply, and it is claimed use called seperti the suppleness to protect children against tuberculosis in high risk area. Vaksin BCG diperuntukkan bagi anak memiliki daerah risiko yang tinggi terkena TB, ini sangat penting. Yang kedua, the number two, whether BCG will be effective remain unknown. Finding from the ecological studies suggesting less COVID-19 in countries without BCG immunization are a weak evidence. BCG administered in the child in unlike to impact COVID. Tetapi BCG ini efektif atau tidak untuk COVID, ini secara riset belum diketahui secara pasti. Apakah dengan divaksin BCG kemudian orang dengan TB ini menjadi tidak terkena COVID. The number three, BCG vaccination called injure a false sense of security. Pemberian vaksin akan memberikan sebuah keamanan khususnya bagi orang-orang yang berdampak atau terkena TB. Careful safety monitoring in randomized trial is needed to guide again the remote possibility that up-regulation of immunity by BCG will exacerbate COVID-19 in a minority of patients with severe disease. Jadi saya kira ini adalah simpulan yang kita bisa berikan satu garis bahwa BCG tetap efektif untuk preventif terhadap terhadap tuberkulosis, meskipun dampak terhadap COVID-19 ini tidak terlalu tinggi. Tadi bisa kita lihat bahwa jumlah yang dari diagram tebar menunjukkan jumlah tetap ada, tetapi berkurang. Lebih baik diberikan daripada tidak diberikan. Next. Ya. Intensive case finding. Penanganan TB dapat dilakukan dalam berbagai hal. Kita mulai dengan yang pertama adalah kita melakukan pencarian kasus. Kita melakukan screening. TB symptom screening dari gejala-gejala yang ada di masyarakat. Kemudian kita memiliki satu asumsi berdasarkan pendekatan tanda dan gejala, orang ini menderita TB. Yang kedua adalah orang yang dicurigai, yang ditemukan dalam screening atau case finding, maka dilakukan diagnosis untuk memastikan seseorang ini terkena TB atau tidak, kemudian dilakukan terapi. Dan yang ketiga adalah protektif pasien tanpa gejala. Orang-orang yang tidak memiliki gejala spesifik TB, tetapi berada di lingkungan TB, maka perlu dilakukan namanya proteksi, pelindungan, misalnya dari kesehariannya, tidak terlalu berdekatan. Makan mungkin sedikit dibedakan atas alat yang digunakan untuk makan, dan sebagainya. Hal ini sama dengan yang dilakukan di COVID-19. Misalnya kalau dia dengan orang TB pakai masker jauh lebih bagus. Dia dengan orang TB tidak sangat dekat, itu juga akan bagus. Karena penularan TB bisa melalui droplet. Kemudian kita melakukan hand sanitizer terhadap orang-orang yang di sekitar kita yang menderita TB. Kalau orang TB penularannya tidak cepat dengan COVID. Meskipun demikian, proteksi yang diberikan atau protokol yang diberikan kepada COVID sangat efektif terhadap orang-orang yang berada di sekitar orang yang kena TB. Next. Focusing exciting TB infection prevention and countermeasures in a higher TB and SIV, but setting to mitigate COVID-19. Kita bisa lihat yang pertama adalah tanggal 1 Februari sampai dengan 5 Mei 2020. Itu ada sekitar 3.240 dari 3.590 pasien yang di screening atau 90%. Kemudian 110 atau 3%-nya dari yang di screening adalah orang dengan TB atau COVID. Kemudian dari 110 tidak dinyatakan COVID dan 4 diantaranya adalah diagnosanya TB. Ini menunjukkan bahwa di lingkungan kita dari sekitar 3.000, kalau kita memiliki penduduk di Indonesia 300 juta, ya kira-kira dikalikan dengan 1.000 atau kurang lebih 3.000 sampai 4.000. Ini akan menderita COVID atau diagnosa TB jika mereka menderita TB. The next. Ya. Contact tracing TB COVID and COVID-19. Bagaimana kita melakukan terjadinya kontak transfer TB dan COVID? The first, identify high risk index, case and exposure, yaitu resiko dan keterpaparan kita terhadap lingkungan atau terhadap orang yang menderita TB maupun menderita COVID. Jadi kalau kita berada di lingkungan itu, lingkungan TB, ya kita berisiko kena TB, lingkungan COVID yang berisiko kena COVID. Maka protokol kesehatan tetap menjadi sangat efektif di berbagai situasi. Jarang sekali orang akan mengatakan seseorang ini kena TB, kemudian mengaku TB, atau kena COVID, kemudian mengaku COVID. Oleh karena itu kita akan lebih aman, lebih lebih proteksi apabila kita ini tetap melakukan protokol. Kedua, the number 2, adapt to the stage of transmission. Kita harus memahami transmisi bagaimana TBC ini menular maupun bagaimana COVID-19 ini menular. Orang-orang yang sudah komorbid khususnya TB harus sangat proteksi, harus sangat hati-hati bahwa protokol menjadi salah satu andalan di dalam melakukan hubungan terhadap manusia. Jangan sampai menyepelekan, karena ini orang-orang yang berisiko. The number 3, ensure community engagement. Kita harus memberikan pemahaman yang baik kepada masyarakat. Sifat tidak percaya terhadap COVID itu tidak baik. Lebih-lebih kalau kita dalam kondisi atau bekerja pada lingkungan dengan orang-orang yang memiliki komorbid. Next. Kita bisa melihat satu penelitian yang dihasilkan oleh Yuan Cheng, ya, Contact Tracing Assessment of COVID-19 Transmission Dynamics in Taiwan and Rise at different exposure periods before and after symptom onset. Jadi kita melihat bahwa penelitian dilakukan oleh Cheng, ya, tentang kontak tracer pada COVID-19. Bagaimana kita melihat di situ? Next. Sekarang kita coba lihat kontak tracer atau tracer terhadap orang per orang, ya. Kontak tracing TB COVID-19 high and low tech. Kita juga bisa melihat teknologi seperti menggunakan aplikasi seperti aplikasi epid dan lain-lain, kita bisa mendetek. Mestinya suatu saat orang-orang itu akan didetek apakah dia menderita satu penyakit yang bisa didetek pakai aplikasi. Jadi kemungkinan nanti kita itu ada aplikasi, orang itu di dalam handphonenya akan tertulis saya menderita COVID, orang yang di sekitarnya otomatis dengan aplikasi itu tahu. Dia akan otomatis menjaga jarak dan lain-lain. Saya kira suatu ketika akan arahnya ke sana. Next. Social stigma associated with COVID-19. Kita bisa melihat stigma-stigma yang muncul, ya. Banyak orang yang mengatakan orang yang belum terkena COVID itu sudah dicurigai sebagai COVID. Ini tetap proteksi yang baik, tetapi menjadikan sosial community menjadi hal yang tidak bagus. Kemudian yang kedua, kita lihat, ya, what master, ya, people who may have COVID-19, not COVID spread. Jadi dia tidak suspek, ya, tidak COVID, tapi ini sudah kita curigai sebagai orang yang COVID. Seharusnya menyebarkan tentang fakta dan support, tidak membuat stigma-stigma yang negatif. Karena ini akan menjadikan kita ini akan hidup menjadi sangat sulit melihat orang selalu dicurigai. Maka di dalam IFRC, stigma yang kedua adalah spread fact and support gnostic journalism, social media, and governance politik. Jadi ini kelihatannya banyak sosial media, jurnalis menulis, atau pemerintah di dalam sisi politiknya ini seakan dibesarkan Ini tentunya akan bikin stigma bahwa COVID suatu yang sangat menakutkan, sehingga justru akan memberikan efek penurunan terhadap kemampuan. Next ya, kita bisa melihat perbedaan antara COVID dan TB. COVID-19, next, sebelumnya. Next ya, that is the back difference of the TB symptom face COVID-19. Yang pertama dari sisi symptomatic progress atau kecepatan tanda dan gejala yang muncul. COVID ini memiliki kecepatan kecepatan terhadap penularan yang lebih cepat daripada TB. Kita tahu bahwa TB penularannya tidak mudah, meskipun kita ini dalam satu kawasan atau satu rumah. Tapi kalau COVID ini sangat cepat. Kemudian kalau kita lihat jenis batuk ya, batuk yang ditimbulkan oleh COVID dengan reaksi yang begitu cepat menimbulkan satu efek bagaimana COVID ini batuknya kering. Kemudian orang menjadi cepat. Biasanya diagnosa ditegakkan dengan bronchopneumonia. Sedangkan untuk TB ini biasanya batuk ditegakkan dengan SCRET ya, yaitu pemeriksaan SCRET atau pemeriksaan swab di TB. Tapi kalau COVID ini cepat ya. Mungkin orang TB dilihat batuknya sampai dengan 21 hari tidak berhenti, kemudian orang dicurigai sebagai TB. Tapi kalau COVID itu masanya pendek, dia akan menyerang efektif di 14 hari. Kemampuan kita di dalam melakukan proteksi atau meningkatkan imun menjadi salah satu solusi untuk mampu melawan COVID-19. Kemudian demam ya. COVID menimbulkan demam yang sangat tinggi yang menjadikan seseorang ini imunnya menjadi sangat cepat untuk tergerus, sehingga berat badan, kemudian kemampuan berpikirnya, kemampuan paru ini diserang dengan cepat. Oleh karena itu demamnya COVID ini tinggi. Sedangkan TB itu demamnya tidak tinggi, rendah tetapi terus menerus. Kemudian gangguan pernafasan akan dilaksanakan berat oleh COVID, sedangkan TB bertahan dan lama. Inkubasinya berbeda, inkubasi untuk TB bisa 2 minggu, bisa sampai 1 tahun, sedangkan untuk COVID kita lihat di berbagai informasi adalah 2 minggu. Testing for TB based COVID-19, the SISO simultaneous testing ya. Yang pertama, cara mengetes dari TB atau COVID adalah tanda-tanda klinis. Saya kira kedua-duanya memiliki tanda yang khas. Kemungkinan terpapar, saya kira dua-duanya dilihat dari riwayat history of disease-nya tentang terpaparnya seseorang terhadap COVID maupun TB, dan faktor-faktor risiko yang lain. Di antara faktor risikonya adalah terjadinya penurunan imun. Mungkin kalau di TB adalah kondisi ekonomi, kemudian status gizi dan lain-lain. Next, intersection, kita bisa lihat bahwa garis yang menghubungkan ini menunjukkan adanya persimpangan orang yang kena TB dengan orang yang meninggal ataupun kena COVID. Kemudian bagaimana kita melakukan maintenance layanan TB? Yang pertama adalah kita harus melakukan protokol kesehatan, salah satunya adalah limited transportation. Jadi kita menggunakan transportasi yang lebih aman, ya, yang tidak berjubelan. Kemudian yang kedua, risiko infeksi di daerah yang rawan. Risk of nosocomial infection in a vulnerable population. Yang ketiga, ensure PPE. PPE is a protective equipment, personal protective equipment, yaitu menggunakan alat pelindung diri. Khususnya di dalam TB adalah pressure for MDR TB provider. Kemudian yang keempat adalah melakukan maintain pengobatan dan diagnosis. Work to maintain medication and diagnosis supplies. Saya kira yang keempat itu penting bagi keduanya untuk memastikan. PPE adalah salah satu perlindungan bagi tenaga medis. Oleh WHO telah dicetuskan sejak adanya wabah Ebola Sehingga dengan PPE diharapkan yang menolong ini akan menjadi lebih proteksi. Saya kira itu mengenai TB dan COVID in the SUTS webinar international UMKU with Taiwan. Thank you very much.
One more time, try to give a big applause to Mr. Rector Rusnoto for wonderful presentation. Right, talking about COVID-19 and tuberculosis is such really interesting topic. But okay, to comprehend our understanding about this topic, we would like to go to the question and answer, sir. So, right, okay, so we will open one questions for the first speaker. So I will let the all participant, for the virtual participant and also the audience here to participate in a question and answer session. Is there any questions? Yes, okay, right. Ibu in the corner. Which one? Okay, Ibu. So please introduce yourself before you deliver your questions.
Okay. Good morning.
Good morning.
My name is Vivi. I want to ask something. Is it true that BCG vaccine can prevent COVID? Thank you.
Okay. So the questions from Ibu Vivi.
Yes.
So what's the question? One more time, please. Would you please repeat? Okay.
Is it true that BCG vaccine can prevent COVID?
Right then.
Thank you.
Okay, so sir, for the first question, is it true, as your explanation, that BCG vaccine can prevent the COVID-19?
Yes.
You mean like that? Yes, sir. Okay, so you have.
Okay, thank you very much, Ms. Vivi. Tadi saya sudah coba lihatkan bahwa vaksin TB, vaksin for TB, different to vaksin for COVID-19. Tetapi vaksin BCG akan mengurangi terjadinya kasus TB. Dengan terkurangnya TB, maka komorbid terhadap terjadinya COVID-19 itu akan menjadi berkurang. Jadi ini dua vaksin yang berbeda. Vaksin is specific disease. Ya. Jadi kalau kita menggunakan vaksin BCG yang biasa kita gunakan untuk TB, tetap efektifnya untuk TB. Dengan jumlah TB yang menurun, otomatis kasus COVID juga akan relatif menurun. Karena TB merupakan komorbid terhadap COVID-19. Saya kira itu mungkin translate for English.
So that's the explanation from the first speaker to Miss Vivi. Is that answering your questions? Yes? Okay, okay. And then we would like to open one more question, sir. Is that okay? Okay. So one more question, one last question. Please, I invite all virtual webinar participants and also audience here to join the question and answer session. Is there any more questions? Is there any from the chat room, please? Show us. Okay. Okay. One more question. Okay, right. So the question from Ibu Atun, the question, sir, can we detect the tuberculosis and COVID-19 with the same way? So can we test or can we detect between TB and COVID-19 in the same way? Right. Okay, sir.
Okay, yeah. TB and COVID similarly about detect of disease. TB and COVID is difference. Jika TB dideteksi pakai ronsen, pakai SPS ya, sewaktu bagus waktu di dalam pemeriksaan sputum. Tetapi kalau COVID itu pakainya swab. Alat yang digunakan tentunya berbeda. Kemudian tanda di awal adalah hampir sama. The same symptom either starts COVID or TB. Dia memiliki satu gejala awal yaitu bronchopneumonia, Mr. Syafiq. You translate in English. Jadi gejala pertama dia memiliki tanda yang hampir sama yaitu bronchopneumonia. Hanya BRPN untuk COVID jauh menyerang lebih cepat, ya, lebih cepat sehingga orangnya menjadi sesak dan lain cepat. Sedangkan untuk TB lebih lambat. Saya kira untuk deteksi berbeda ya, berbeda. Swabnya hampir sama, mengambilnya seputumnya, tetapi alat yang digunakannya berbeda.
Right, if I can a little bit give an explanation from first speaker that maybe a both of BCG and also between tuberculosis and COVID-19 can be detected in the same way for general, but in a very specific, it could be different, yes, sir. So if tuberculosis can be tested by month of test, but COVID-19 can be done by swab. And then for the symptom is really different. So in a tuberculosis, the fever can be really rare. But in COVID-19, the fever could be high. If I'm not mistaken, it's like that, sir. Right? Maybe there are no more. Okay. Yeah, I think enough for the first presentation delivered by Mr. Rusnoto, the rector of Muhammadiyah University of Kudus. So this is the first session for the first presenter, and then we would like to say thank you to Mr. Rusnoto. Would you have any closing statement, sir?
Thank you very much for participant, and thank you very much to Taiwan collaboration Universitas Muhammadiyah Kudus with Taiwan. Thank you very much.
Right, and before Mr. Rusnoto leaving the stage, maybe I will invite you to take a photo session together with the second presenter. And then now I will stay connected to the second speaker, Professor. Hello, have you been with us?
Hi, hello.
Professor Liao?
Yes,
Have you been connected with us? Okay.
yes, connected.
Sir, okay. Before you give your presentation, maybe we will have a photo together with our rector, sir. So now we will have a photo session together. Okay. Right. Now and then I will invite Mr. Rusnoto and also Vice Rector to join for the photo session together. Vice Rector 1, 2, 3, please come to stage to have a photo session. Sir, would you listen my voice up there? Hello?
Yes, yes.
All right then.
Loud and clear.
Okay. Right. So now we will have a photo session together first. Okay. Right?
Right.
Okay. 1, 2, 3. Once again. 1, 2, 3. Freestyle. Okay. Freestyle. Freestyle. So 1, 2, 3. One more. 1, 2, 3. Okay. And then I invite all participants, please. I invite all audience in this webinar, please, to join the stage to take a photo session together, please.
Mm. 我应该要再减肥了。
就老师，你真是公平的，因为你的脚步是从下往上，而且你的点放的特别大，就是他们都是想把你的荧幕用全荧幕要投出来，对，就人看起来就
肥了，
不是比较靠
All right. Okay.
先开始小一号那个。
1, 2, 3. Again. 1, 2, 3. Freestyle. 1, 2, 3. Again. 1, 2, 3. All right then. Thank you very much. Right. Give a plus. Thank you, sir. Well, ladies and gentlemen, now we will begin the session 2. Together with us, we have a really expert speaker who will talk about Taipei healthy cities in the post-pandemic COVID-19 era. Before Professor Liao deliver the presentations, let me introduce him first. So his full name is Liao Hung An. Now he's a professor, and then now he is in Department of Healthcare Administration, Associate Professor, Department of Healthcare Administration, Asia University. And then Professor Hung En Liu, a faculty member of Department of Healthcare Administration in the Asia University, has multiple integrated expertise in the field of health policy, health promotion, healthcare, and long-term care management. He graduated from Department of Public Health, National Taiwan University, and he got his PhD degree in the Department of Health Policy and Management, Johns Hopkins University. Professor Liao has been served many committee member in central and local government of the past few years to assist government on the planning of health policies and healthcare management. Oh my God, give applause, please. As well as in the cooperation for long term in the remote area, health promotion among aborigines and vulnerable groups, and healthy long-term athletes. In addition, he exhibits a remarkable ability in academic research and has been recognized for the excellence in academic book writing and journal publication by Asia University in recent years. Oh my God, really, really wonderful. And Professor Liao, would you be ready for your presentation?
Okay.
Okay, now the floor is yours, sir.
Okay. Distinguished audience, far from and far to Indonesia side, and my name is Liao. I'm an associate professor in Department of Healthcare Administration in Asia University in Taiwan. In addition to that, I'm also serving as a director of a think tank of our capital city, the Taipei City Hall government. So I would like to introduce the topic, the Taipei healthy city in the post-pandemic COVID-19 era. As a public health scholar, my entire life, my mission is to improve the equality of people's health. So as you will know, if we want to improve the health status, improve the health of our people, the influencing factor itself is not only include the direct factor, but also we so-called contextual, we so-called social determinant of health. So today I'm going to tell you very big topic, the government, how to we have a good governance, okay? Then my briefing outline will be include 4. The first one is the impact of the pandemic. The second outline will be Taipei City actions. The third one will be international actions. The final one will be future outlook. I will demonstrate and introduce what our government, from central government to our capital, our Taipei City government, just like Jakarta, how do we do to prevent the COVID-19, and what have we done, and what are we doing, and what will we do in the future for the future 5 years. So far, we can see the pandemic, the COVID-19, is have a very deep impact on all the countries in the whole world. For the future 1 year, I don't see anything. I believe in the future 10 months, the border still closed around the whole world. So what can we do to adapt ourselves to a new normal? And I begin my presentation. Okay, I will tell you our trajectory review. When we face the COVID-19, I divide it to 3 stages. The first stage is the immediate impact. How do we do on the contingency plan? The second phase, we call it resilience. How do we recover to our new normal life? The third one is that how could we do to combine our people, our government, to have a better normal life and our plan in the future, okay? Then the first one is the impact of a pandemic, okay? Then, as you know, before we talk about that, I will overview of our Taipei City. The Taipei City is a city with a total population of 8,500 people. And we have very high density. And as you know, not like in Indonesia or Jakarta, our population, we have a very high percentage of population over age 55. I tell you one figure, that one number that in Taipei City, the people aged 65 and above occupy around 19% of our Taipei citizen population. Our total fertility rate is 1.21 per thousand, and our infant mortality rate is 3.6 per thousand. Then our life expectancy at birth is around 83 years old. So just like in Jakarta, in the future, now we can see a lot of people crowding the big city, the metropolitan city. In this kind of city, then what problem will we face? First one is urbanization. Just like in Jakarta, we have a traffic problem. We have a living quality problem. We have a COVID-19 problem. We have food hygiene problem. And the second one is aging problem. The labor force. Are they feel safe? Do they love their work? And our healthcare resources in Taiwan, is it sufficient? Our have a senior care pressure. Our elderly welfare and protection, how we protect our citizens. And also we have a low birth rate. Then it will impact on our future manpower supply. And how do we subsidize our parents to their child care and education? How about our school security? Do our children could happily learn in their school? And also we are facing the climate change, especially facing on so-called global warming, air pollution, ecological impact, and so also a lot of international environmental issues. Then the final one, as an international city, we have a multicultural impact. As we know, we have also more and more Indonesian and other people in Taipei City. We need to conserve their life and their cultural adaptation. And we need to introduce our technology innovation and also face we so-called getting on our housing problem, the employment opportunity and the housing security. Face so many problems. How do we do? Okay. Then in 2015, at the end of 2015 or 2016, the Taipei City Hall decided to integrate all the 31 department or bureau to establish a health city interdepartmental cooperation promotion organizational framework. Why? Because the health is a basic human right. We would like to build a people-centered project to help our people. So we decided to establish 5 task work group, including we so-called security and safety group, and also sustainable ecological group related to the environment, and also our friendly culture group. The first one is vitality and the health group. The final one is we so-called convenience and the prosperity group. Economy is also a very important issue. So we will make sure every action plan in this city hall, they have health in all policy. That's our plan. So in all of 31 departments and the bureaus, they are not only divided into 5 different task groups, but also we would like to depends on the issue. If the issue involves different department or different bureau, they need to have a representative or the director need to represent to their task force group to solve those projects or we so-called action plan. Then we also have 67 indicators to implement all the health city action plan, all the age-friendly city plan, and also local community security indicators. So as you know, those 67 indicators, they will be divided to 9 from the international indicators, 48 will be local indicators. So you can see the dividing. We use the indicators to monitor our action plan. Then, as you know, in the 9th Global Conference for Health Promotion, Health in Shanghai in 2016, at the conference, all the delegates, member of the country declare the Shanghai Declaration to on the health promotion. They declare they hope all the city in the whole world will contribute themselves toward achieving we so-called UN United Nations SDGs, meaning sustainable development goal. So from 2016, we decide to transfer our health city to reach we so-called achieving the UN SDG goals. So in 2019, Taipei City has become the 10th city in the whole world to to publish with so-called voluntary local review papers, okay, VLR, as you see in the final purple one. We declare among those 17 Sustainable Development Goals, we would like to set up 7 priorities, okay? Those 17 Sustainable Development Goals, according to WHO and the UN, they encourage all the cities need to be done, all the 17 goals, but you can set up the priority. So in 2006 and 19, we set up 7 goals, 7 goals as our priority. In 2020, this year, we add 4 more goals. So far we have 11 priority. We will talk about this later, and we also lost 67 action plan distributed in those 5 task groups. We have connected to those Sustainable Development Goals, as you see in the left, down left on the screen, you can see. So next we'll talk about, but as you know, the COVID-19 for the past years, those and this picture are the updates, okay? Update of this November 26, okay? These are the COVID-19 dashboard. There you can see all around the world. We have a lot of cases, new cases. We have a lot of conferences, and we have a lot of people. We have more than 1 million people dead all around the world. But how about those impact in different countries? As you know, this one is the international comparison of the evidence on COVID-19 death and the GDP loss on the Q1 and Q2 this year. This report is reported by British Economist Journal and also by the Stanford University on their working paper. Okay, so it's a very brand new report. You can see this figure. This figure is the international COVID-19 death and the loss GDP. You can see these are United States, a lot of death, and there will be a lot of GDP loss, around 3%. And you can see our Japan. These are the OECD country, and also they compare those a lot of countries in the whole world. But these are Japan here. Japan, they don't have a lot of people death, but they have a very huge impact on their GDP loss. But as you know, on this figure, you can see the Taiwan. Taiwan is like in Japanese cartoon, we call it corner creator. Corner creator. Why? The Taiwan is the exception. According to the Stanford University report, Taiwan is the exception. Why? We barely have people dead, and our GDP loss. We almost have no impact. Our GDP loss. Why? How come? So let's experience. I would like to share with you how our government has been done and how our city, the Taipei city, our capital city, has done to share our experience to you. You can see, according to the international, in the whole world, they usually use the 3 T. What do I mean by 3 T? The 3 T means test, big scale test of all the people to see where is the source of infection of COVID-19. Okay, it's normal, it's logical. The second T, we call it track. We track all the people. You know, there's we so-called a blank period. Okay, so people might have a COVID-19, but without a symptom. How do we know? We track. Let's track. The third one, the purpose of a track is to avoid we so-called community infection. The third one, we call it treatment. So the 3T meaning big scale test, track, cases. The third one will be treatment. Okay, in the future, okay, from December, as you know, see the news that United States decide to have a vaccination from this December. But but how do we how Taiwan has been done for the future, for the past? Okay, in different from all the country in the whole world. Taiwan, we learn from lesson, our SARS lesson in 2003 years at a time. So we know we suspicious the COVID-19 very early in the last December. So the first thing is we use the so-called border control. Border control. Then the border control, the first step. Then the second thing is we managing the crisis. How? Then we have a lot of we encourage, like right now it's very popular. We encourage people to wear masks, to wash your hands, and to keep the social distance. Right now it's prevail around the whole world. But the third one is quite unique. It's quite different from the whole world. Is that we have an open government and we build a precision epidemic prevention model. How? The first one we so-called contingency plan is that you can see we so-called big data, technology big data, which is innovative technology that facilitate case identification and also epidemiological investigation and the quality in Taiwan. How? As you know, Taiwan is we have a national health insurance system. So 99.9% of the people we have a national health insurance card, everyone. So we connect those national health insurance card information with we so-called entry quarantine system. Okay, as you know, everyone when they come from the outside country, they will pass the custom, pass the border. So we connect those information with our national health insurance card information system. So the travelers are required to fill a hard copy of electronic passengers health declaration for immigration clearance. The electronic version is easy to access with scanning QR code before boarding, while we expedite immigration declaration upon arrival and tracking the travel at risk of contracting COVID-19. And we also home quarantine information system is the issue to travel at risk. But as you know, a lot of people that come from different countries. So when they pass the immigration, we so-called red eyes to scan their temperature. As you know, we got to have somebody with COVID-19 virus, but without any symptom. So when they pass the border to go to our country, we have a second fence. We call it automatic notification of a travel history in clinic. Once those people have a symptom, okay? So as you know, as I depict, that almost all citizens receive healthcare service under so-called single-payer health insurance in Taiwan. Record of entry into Taiwan since January 13, okay, within 14 days, as provided by National Immigration Agency, was incorporated into we so-called national health insurance, the medical cloud system, to notify physician the travel history of the patient. Once they have a symptom, they will go to the doctor. Then, the doctor will immediately know, okay, this patient, do they have a past travel history for the past 14 days? Okay, so we will have an immediate isolation. The third one is called epidemic prevention tracking system. The messenger application, okay, is a two-way messenger help people under home quarantine or home isolation to regularly report their health condition. The system is integrated into government network, so therefore is able to notify civic affairs or people, a police agency, if further assistance is needed. The fourth one is cell phone based on electronic fence system. Right now is popular adopted in all over the world. Okay, the system monitor the location of the epidemic prevention mobile home, distribute to people in home isolation or the home owned by people in home isolation if informed consent is obtained. If it send real-time, alter the police and the local official once they leave the designated isolation place. The fifth one I didn't mention, I did mention, but I didn't post in this one, is we have a mask map system. The mask map system is an endeavor by our non-for-profit, non-for-profit organization, and also the government. They cooperate with each other. So once the people they need to buy the mask, so they could have an app in their cell phone. They could see, where can I buy the mask and how many masks left in their we so-called pharmacy store. So it's very convenient. So for everybody, if they need the mask, we call mask system. So that's for the central government they have done. But for our Taipei City government, what action do they have? As you know, the COVID-19, the impact to the SDG seems in health department, the SDG, good health and well-being, have been devastating the effect on health outcome. So Taipei City government or Taipei City Hall, what do they do? The first one, as I depicted earlier, we have a contingency plan. The second phase we call resilience phase plan. The third one is that we have a better than normal. I would like to remind you that all the contingency plan, we are focusing on environmental control. The second we so-called resilience, we call it economic boost period. The third one, we call it social reform. So from all the public health improvement, always from history, is from environment, move to economy, and move to social reform. Okay, so we have 14 measures. Okay, the Taipei City government response measures to central government and to this COVID-19, including secondary care. I will depict this later. The second one, resilience. The Taipei City Hall, they have a 9 citizen relief program. And also we have a boost program to stimulation our economy. And so-called, the third one is transformation program. Okay, that's our resilience of Taipei City. The third one, it is our capital city. We are not only satisfied by our so-called right now, everybody knows it's called new normal life, but we have an ability to let our Taipei City people have a better quality of life in Taipei. So what do I do? Or what do our government do? How do we cooperate with our citizens to do? Okay, I will reveal our plan in the end of this presentation. Then, as you know, in our contingent plan, we have an anti-epidemic hotel to those we so-called home isolation or we so-called high home quarantine people. Okay, and so far, okay, we have received 14,000 people in those we so-called anti-epidemic hotel, and we also provide 2,360 rooms for the people. The second thing is we have police, firefighter, and the medical personnel rest station. As we know, well, they check 2,000 every day. They are very busy. So also we provide a lot of comfortable restroom for rest station for those firefighter and police. And third one is anti-epidemic hotel handbook for those who are a little bit panicked, those people. So we have their handbook to their review how to adapt themselves to those 14 days isolation or quarantine period. And our life, as you know, our life have a little bit impact, but our economy almost do not have an impact. Okay, so we will real-time epid to help. So in addition to that, our second period is that we have a tax delay and the rent deduction, price reduction, variable interest rate, allowance for the we so-called disadvantage. We have a tax deduction for those merchandise, and also rent delay for those we have their own house, and rental termination and short-term employment for those disadvantaged. So as we see, the Taipei City government from last year, the profit-seeking enterprise sales amount in Taipei City compared to the same period in 2016, 2019, and this year, 2020, there's almost no impact. Okay, that's our second phase. The third phase is that we also have a boost economy, encouraging travel program. We have a lot of subsidy and upgrading travel program. Okay, that's our, in addition to transformation, and also our transformation policy instrument, including we use multiplier effect in we so-called economic theory. So we subsidize people is less than $2,000. We subsidize $1,000. So that's through our, also in addition to that, since we have an aged society, through the senior card, paying on cash, using habit for elderly people to achieve their objective of future over or society transformation and cashless city. So encourage them to use those during the transformation. So, but in addition to Taipei, what can we learn? What can we learn from the international society? Okay, as you know, the European health city, their response to COVID-19 pandemic, they found three conclusions. The city are all often national and international epicenters in the COVID-19 pandemic. The second conclusion is that cities are the close level of government to the people. The final one is cities are operational partner of the national government. So, as you know, the needs assessment, the WHO European Health City Network, they're focusing on 4 priority areas. One is their mental healthy. Okay, why? Because since around the whole world, there are a lot of people isolation, a lot of people death. So the mental healthy is very important. The second one is group at high risk of vulnerability, especially older people and children. The third one is homelessness, support and providing shelters. The fourth one is WHO and the UNESCO to partner on the sharing resources and the link to the two networks to support the COVID-19 responses. In addition to that, how the European office of the WHO, what do they do? they decide to fund a lot of their money, their euro on those 4 programs. The first one is the Mental Health Coalition. The second one is Empowerment through Digital Health. The third one is European Immunization Agenda. The fourth one is Healthier Behavior. Their target is to provide 1 billion more. 1 billion people more have a universal health coverage, which has been done in Taiwan long time ago. They also wish to have 1 billion people have a health emergency. They wish to have 1 billion people to have a health and well-being. That's what they've done. In Japan, since we have a stay-home plan, a lot of people, they will be isolation. So they use, as you know, the Japan has a lot of very good cartoons. They use the Doraemon figures to help people to stay home, to don't feel like loneliness or boring. So that's what they do. Doraemon, stay home plan. But how about in Australia? Okay, they have a healthy city action plan in southwest province, Southwest Wales province in Illawarra. Okay, they focusing on the loneliness program, the mental health program, and also since there are a lot of disadvantage, the poor people, they do not have a food they cannot buy food in supermarket, so they have food security and encourage people to their community to grow their plan, the nutrition program. And also for those 9 to 12-year-old children, they initiate an active in-between program, okay, to those people empower their literacy, health literacy. And a lot of program is called 5 kilometers once a week, 5 weeks, we call Kiyama 5 times 5, okay, to encourage to keep exercise while staying home. So also they have a good cheer check and their program, which is more and more popular in Taiwan and also I believe in Indonesia. So they include people and walking and cycling. These are their improvement. So in Taiwan or in Taipei, what do we do? I reveal our answer. Okay, since in Taipei we have those are 17 SDG group. We're focusing on the third one in the center. How do we do? These are the recommendation by the WHO. We need to have city action plan domain on those 9 action plan, which could be reference for Jakarta. But in Taipei, since in Taipei City, we have given priority goal in 17 SDGs among those 17 SDGs. So so far our program in Taipei, our action plan has been corresponding to 12 SDGs. So how do we do? So in the future, in safety and security task force group, we are okay, let me put it this way. We begin with this one. Our vitality and health group. Since people will be isolated or when life will be inconvenient, so we would like to be active for physical and mental health. That's the direction we like to forward. And second will be, So the second will be prosperity and the convenience group. We will focusing more on the digital service for those disadvantaged, not only for we so-called distance telemedicine, but our we so handicapped when they don't need to transfer from bus to our subway. Those things we have a more we so-called universal cap to help. The third one is called safety and the security group. We would like to build a comprehensive low-hazard network because in this group we are dealing with low high-risk group. People do they feel like they love their work? Do they have under those domestic violence? People are feel suicidal people. Those are vulnerable people. We would like to build a very comprehensive locus network. The fourth one is called Sustainable Environment Ecology Group, which we will put our innovative living environment. The final one is Friendly Culture. It's called Learning and Accompany Health Agent. So in this one, the agent, we would like to initiate a lot of program, keep people company, so people don't feel loneliness. Okay, so as we have been done for the spongy city, and also we have a garden city, and we initiate a lot of healthy air, fresh air program, and as we know, the technology in Taiwan are very high, so we have a smart city, build a public-private sector cooperation, a lot of program, and we have an inclusive program. So those programs in our community, they are not only for healthy children, but for those who are handicapped children, also could play. So it could call it inclusive, universal, inclusive program. So,
Professor, excuse me, you still have 2 minutes to finish your presentation.
Okay, yes, okay, 2 minutes. Thank you. So we initiate our methodology, which is published by European and Journal of Public Health. We use E48. So these are the methodology for PES-led and led. So as you know, the experience learning from AFHC, which is Alliance for Health City in our Asia, the conference Let and Learn. When we promote, we fight COVID-19, we must see systematic approach. We need to form a partnership, human-centered, participation mechanism, and the technology application. So the final one, the answer for better than normal is we use the APP self-management, the digital service, and Taipei and I will aging program and complete social security net. And finally is green industry innovation. So that's the answer for our future. The future will be implemented in this year, 2014. In essence, we can see those programs. The essence is self-help, help others, mutual help, joint help, and common good. The only thing is everybody is common good. Everybody is good, then the society is good. Okay, that's my presentation for health for all. Thank you very much.
Right, that is the wonderful presentation from Professor Liao. And to comprehend our understanding about the presentations talking about tuberculosis and COVID-19, now we will go directly to the open questions or question and answer session. Is that okay? We will go directly to the discussion session, sir. Right?
Yes.
Okay.
Right.
Okay. And yeah, to comprehend our understanding about the presentation, please. Now I invite all webinar participants to join the question and answer session. And also the participant here, if you have any questions, so just participate in the question and answer session. Now I will invite 2 participants to join the question, please. Is there any questions? Oh, yes? Okay, lady at the corner. Introduce yourself before you deliver your questions, please.
Okay, thank you to Mr. Syafiq. Good morning, Prof. Liao. Hello.
Hello.
Okay.
Yes.
My name is Edy Wuryanto. I am in UMKU, is lecturer chemical in pharmacy. And now I'm so interested about your topic. And I want to ask, until now, the total of COVID-19 in Indonesia still high. One day, the increase of COVID in Indonesia is more than 5,000. maybe you have a suggestion for us how to survive for COVID-19.
Okay, that's the question. Yeah, if I can.
Yes.
Okay.
Okay. Okay. They are okay. As we know, in the national society, we so-called 3T to fight the COVID-19. The first one is test. The second one we so-called track. The third one we call it treatment. Right now in Indonesia, the most important thing is, I don't know in Indonesia, do you have a very big medical capacity for we so-called mask, we so-called big scale of screening, okay, to test your RNA, those big screening. If you have a big budget, and also you have a big medical support and capacity, then you could do this one. But I doubt it. So the second thing you need to know, my suggestion to you is to how do you avoid the spread in the community? That's the second phase. So my second thing is, my suggestion to you is that, okay, there are three strategies for you. The first one is we need to have a very huge, massive, we so-called health education. The health education is that we encourage your people to wear masks, to wash your hand, to keep the social distance. I believe you haven't done those strategies right now, but the second thing, this one is that before you waiting for your vaccination, okay, then health education is a basic, but very basic one. But the second strategy is that you should learn from our government is open information. What do I learn? The open information is that usually people have some rumors. So you can have open questions that you should have we so-called press conference every day. So and let people know and what can they do to cooperate with the government. The Taiwan, we could do so well is that we communicate between the government, not only the central government, but also local government and the press and the local government and the people. We communicate with each other every day to keep all information open and connect. That's the second strategy. The third one is that use all technology you have to avoid we so-called community spread out of the COVID-19. So this one is very important, okay?
Right. So that's the wonderful answer and explanation from Professor Liao to the questioner. Is that answer your questions? Yes?
Yes.
Okay, thank you very much.
Sir.
Right. And then now we will have another question. Please, I will invite all participants and also chat room questions if we have any. Okay. Is there any live questioning?
Yes.
Okay, right. So, okay, to Ibu, so the floor is yours. Introduce yourself before you ask the question, please.
Okay, thank you. My name is Amalia. Thank you, Professor. That is a nice presentation. In your presentation here, you explain about tracking system in Taiwan by using technology. Can you explain that? Because I think this is very new in Indonesia. This is new in Indonesia, tracking system by using technology. Thank you.
Okay. Okay, let me put it in this way, okay? imagine you are people living in, you are Indonesia, you are a Taiwanese, okay? We Taiwanese living in New York City, okay? After the pandemic of COVID-19, oh, people are scared, so they want to come back to Taiwan. So what do they do? They take the airplane to Taiwan. When they arrive to immigrate, when they pass the we so-called custom or immigration borders, all your information will connect to your we so-called national health insurance card. The national health insurance card is a card that when you go to doctors, when you go to anything, but how about for those foreigners? If foreigners, they will connect to their passport. So but when you pass the immigration, you might get infected in New York City, but you have no symptom. Nobody knows. When you pass the immigration, the temperature is normal. So nobody knows you are infected with COVID-19. But when you pass the borders, okay, go back to your home, maybe your home in Taipei, then something happened. You don't feel comfortable, you smellless, you did not feel anything, or so you decide to go to the doctor. When you go to a doctor, the doctor uses your national health insurance card to insert the machine to see, oh, it will connect, okay, this passenger, this patient, oh, for the passing 14 days, you stay in New York. You just passed the border 2 days ago. So, wow. So they need to, so all the clinic or hospital, the physician will say, okay, since you have symptoms and you are for the past 14 days, you need to quarantine. So we should isolate these people for 14 days, or they've had to test. So we did not adopt we so-called big scale test among all our people. Is because we need to reserve our medical capacity for the future health. So that's the key word. That's the key mechanism. Okay. So all the we so-called big data connection, and also if you under your isolation or quarantine period, you need to stay in some hotel, and for 14 days. During these 14 days, you cannot go work outside. And since you have your cell phone, the cell phone will tell you you can use the cell phone. Then people will send you food. Of course, the government will subsidize this living, and also order the food. The food will send to you the corner of your room. Then during these 14 days, if you, of course, there probably some people will sneak out to the street. If they do that, then since they have their cell phone, the cell phone will immediately notify the police. The police will find them, and we have a very, very big fine. It's the punishment, the fine is very huge. It's around, I remember, is $30,000 US. Okay, it's a very big fine. Then also I remember in Taiwan, how about if we are not confident, I remember in June, we conduct a community research to see if the community, the more scale thing in Taiwan society or in Indonesia society as well, is that we are afraid of we so-called community infection. Once they will have a community infection, they will spread out all the society. So we conduct research to see how many potential COVID-19 people without symptoms. We test their RNA, but the evidence shows that it's very, very small in Taiwan society. So far, as I remember, so far from last year to now, we have only 40 people dead in Taiwan. And those 40 people dead in Taiwan, they are all from the outside borders. Not single one is in our society, okay? That's what we have done.
Right, so that is the wonderful explanation and answer from Professor Liao. Exactly, there are a little many questions coming to us for the wonderful presentation from Professor Liao, but the time for this session is going to be finished, so
yes.
I might close this session. Then before I close this session, I'd like to say thank you very much for Professor Liao for wonderful presentation. Before you close your presentation, would you give any closing statement, sir?
Okay, my closing is that to build a healthy city is not only for health department's business, it's everybody's business. So in the national society, if Taiwan is good and Indonesia is poor or bad, it's not good. What we want is that Indonesia society and the Taiwan society is we both are good. So if you have any question or if someday I have a chance to visit Indonesia, you will invite me to Indonesia, I will share more our experience to you, how we fight together to COVID-19. Thank you so much.
Thank you very much to Professor Liao. One more time, give a big applause. Thank you very much, Professor, for the wonderful presentation. And I must close this session. And then now we will go directly to the third session, right? Okay, we will go directly for the session 3. Yes, right? Okay, so I might keep in touch with the third speaker, Dr. Rebecca. Have you been connected with us? Dr. Rebecca? Hello there. Yeah. Have you been connected with us? Doctor? Yes?
Yes.
All right then. So for the third session, the presentation will be delivered by Dr. Chou-Jui Lin. But before she deliver the presentation, maybe we will have a photo session together. So we will. Dr. Rebecca, have you been connected with us? No? Okay. Right. So now we will have a photo session together with the Dr. Rebecca first. Okay. And then I invite all webinar participants here to join the photo session together. Please come to stage, everyone. Vice Rector 1, 2, 3, please. And also all webinar participants here to join the photo session together. Okay.
PowerPoint 的那个 Microsoft PowerPoint 的那个分享号，对，如果要把它现在开了，现在开了，现在会有帮助。
Okay, ready? 1, 2, 3. Again. Dr. Rebecca, would you please slide?
Can you hear me?
Okay, so now we will have a photo session together first.
Hello.
Print off your material.
Do you have my slides here?
Okay. All right then. So one more time, please. We will have a photo session. 1, 2, 3. 1, 2, 3. Dr. Rebecca, would you please face to the camera that I can give?
Yes.
Okay.
我的电脑关一关。
Okay, right, face to the camera.
电脑现在现在是长这样。
Okay, one more time. 1, 2, 3. 1, 2, 3. Now freestyle. Freestyle.
这样听得到吗？
Okay. Freestyle. 1, 2, 3. Right, thank you very much.
Okay, can you hear me? 现在是要拍照，所以老师可能要看着这个。但是我看不到他，懂这个。就是现在他们现在就是只是要看着那个脸而已，对他不用看你。但是他不知道听不听到我声音。
老师，你先把那个分享。
对，我要关了。Stop share。好像不是我弄的。是的，是。
Well, ladies and gentlemen, now we will move to the lesson 3. The presentation delivered by Dr. Rebecca Chou-Jui Lin. He will talk about management of MTR tuberculosis in Taiwan. But before she delivers the wonderful presentation, let me introduce her for a while. Her full name is Rebecca Chou-Jui Lin, right?
Yes.
Taiwan. Okay. Taiwan General Hospital, Ministry of Health and Welfare. Her educational background, 1992 to 1999, Department of Medicine, National Chen Kung University, Thailand, Taiwan. And then postgraduate time, 2002 till 2004, research fellow, National Taiwan University Hospital, Taipei, Taiwan. But the certification 2004, license of pulmonary and critical care medical doctor, and also membership in professional and scientific societies, 2004 till present, Taiwan Society of Pulmonary and Critical Care of Medicine, and 2019, member of the Board of Directors of Taiwan Society of Tuberculosis and Lung Disease. About the professional experiences that I can mention one by one, there are so many. In 2018, short or abstract presentation on 49 Unit Conference, May 2019, moderator of international workshop on PMDT by Global Cooperation of Training Framework. And also last, about her publication, there are 5 publications, and then the most common one, she talked about lower prevalence of tuberculosis infection and BCG vaccination, cross-sectional study in adult prisons. Right, to save our time, so we will go directly to the presentation delivered by Rebecca.
Can you hear me?
Have you been?
Hello? Can you hear me?
Okay, so now the floor is yours.
Yes. Do you hear my sound?
Right.
Okay.
Okay.
Okay, great. So, so you can also see my slides.
Okay.
Okay, great. Hello, everyone. My name is Rebecca Lin, and I am a physician from Taiwan. I'm a pulmonologist, and I specialize in tuberculosis care. So today I'm very honored to have this opportunity to share with you about our management system of drug-resistant TB in Taiwan. This is a so-called TMTC, as you can see on the title slide, Taiwan Multi-Drug Resistant Tuberculosis Consortium. So today, I'm going to go through the background introduction to tell you how we established the system and to introduce the care model of TMTC. And if we have time, because before I was told that I only got 25 or 30 minutes, now since we have probably a little bit more, maybe we can have time to do 1 or 2 case sharing. Finally, I will end my talk with my conclusion. So first, introduction. As you know, Taiwan is a very small island. Our surface area is about 36,000 square kilometers, but we have population of more than 23 million. So it's a very highly densely populated area. And we have a lot of hospitals, like more than 400 hospitals. Do you see my slides moving?
Right, but maybe you can give a full slide, Mom.
Okay, oh, okay. So I'll change my, sorry, we'll change to another computer.
All right, right. I can.
Sorry, we come forward and we'll fix it. So, okay. Do you have the full screen right now?
Yes, Mom. Yes.
Okay, thank you. So we have a lot of health facilities. That means that we have pretty easy access to healthcare. And then, sorry, next. No. Yeah. And also the most important thing is we have, since 1996, we have national health insurance policy. And we have more than 99% coverage, meaning that almost everyone in Taiwan will use this national health insurance card whenever they want to see a doctor. And it's during that time, we started to phase out the vertical TV system. We used to have a vertical system. But in 1999, Taiwan CDC knew that we still need to establish a TV system to provide better care. So they established a national surveillance network of communicable disease. It's not just about TB, it's about all the other communicable disease, such as HIV or influenza, things like that. This is how we have accomplished during the previous years. Since the TB incidence rate dropped from 72.5 people per 100,000 a year to like right now in 2017 is like 41. By doing this, we really managed to do this by first mandatory reporting, and we have universal DST. That's all been done during the past few years. And we strictly provided DOT strategy and also followed by latent TB infective preventive therapy. And you can see the TB incidence by gender. It's clear that in Taiwan, probably the majority of our TB patients are male. It's like 2 times higher than female. And if you see the TB incidence by age group, it's really clear that you can see that after age 40 or 50, the incidence rate dramatically increased. And most of the time, our patients in Taiwan, more than 50% of the TB patients in Taiwan are more than 65 years old. So we're dealing with a lot of older TB patients with a lot of comorbidities, and these are the challenge in Taiwan right now. So let's talk about the TB care model in Taiwan. This is the general model. If a patient with symptoms goes to the healthcare facilities using its national health insurance card, then a doctor suspects that this patient might have tuberculosis. The doctor has to notify the National Surveillance Network of Communicable Disease. And after the doctor notified this network, it is an electronic-based system. Then the system will send a signal to the public health nurse and also sending back to Center of Disease Control. In that case, all of the system here are being notified that there is a potential TB patient in our care facility. And the doctor will give the patient treatment while the public health care workers will provide DOT and contact investigation. And after a few weeks, probably, when we have this drug susceptibility test result coming back, we will have the DST result from the laboratory system in the healthcare facility, and we'll send it back to the CDC. It's all electronic based. Also, the system will extract the regimen the doctor has been using and also the body weight of the patient. In that case, CDC can have a better control of the population through this network. And last, the CDC will have a talk with national health agencies. So if a doctor prescribes a lousy treatment, then the CDC will have a way to punish the hospital and also the doctor. Second, how about DRTB? What we have talked about is drug susceptible TB. For drug resistant TB is another story. So let's see how we, sorry. Okay. So let's
Hello, ma'am. Excuse me, I lost your voice.
Did not do a very good job before. So this is a follow-up study done in
Excuse me, ma'am.
from 1992 to 1996. We enrolled like almost 300 patients, the majority of them mean age 47, and let's see the outcome of treatment. It's really not good. So it's pretty much like what happened right now in the world. We have only 51% cure rate. Failure rate is about 10%. 10% died, but we have almost 30% of loss to follow-up. And so, sorry. So this comes the moment when we stop and think, why would this be happening in Taiwan? We have universal health insurance coverage. We have easy access to medical care. We have integrated TB system within the healthcare system. And we also have good public-private mix. And we also, by the way, we have electronic system. So why are we still failing on treating drug-resistant TB? It's apparent for us that we need another system to improve that. So what exactly happened in this kind of system when it comes to a DRTB patient? First, the patient just wants to run. They want to run away. They just want to escape. Why? Because the treatment is very long and contains a lot of pills, very toxic, with a lot of side effects. And these patients are really old, like more than 65 years old, with comorbidities like diabetes, alcohol, and a lot of them were retreatment cases, meaning that they have experienced this before and they knew that this is not good. About the doctor, what are the doctors thinking? They're thinking, I just don't know, because these are not specialized TB doctors. They don't know what is the current policy in terms of treating drug-resistant TB, and also in terms of reimbursement, it costs a lot of money and it's not profitable for the hospital to take care of drug-resistant patients. And lastly, for the healthcare workers, they just want to quit because they have to be in charge of DSTB and DRTB, and they are also responsible for outcome evaluation. All of these provide extra burden on these healthcare workers. So we decided to construct a specialized MDR-TB program to deal with this kind of problem. What's the key components of the MDR-TB program in Taiwan? First is a national surveillance network. I told that before, is an electronic-based system. And first, with coordination between hospital and public health sector. Second, the key components will be the central research lab, because not every hospital in Taiwan has the capacity to perform second-line drug tests. So the majority of the hospital can do first-line tests. But when it comes to second-line panel, then we rely firmly on the central research lab to confirm MDR, to provide molecular diagnosis, and also cluster investigation. And lastly, we need a program that really take care of the system. That would be the TMTC. So let's see the TMTC. So there are 5 regional leading hospitals. It's a designated treatment network. We have 5 clinical teams covering 5 different regions. So basically, Taiwan has been divided into 5 parts, and each part will have 1 leading hospital and associated with other affiliated hospital. and the TMTC. So let's see what's the characteristic. First is a hospital-led care and DOT. So this time, it's not the public healthcare worker to do the DOT. It's the person from the hospital to provide DOT. And also, we strongly suggest initial hospitalization because most of the time we're taking care of older patients. And third part, there is zero out-of-pocket expense from the patient. Before, even though we have national health insurance coverage, our patients still have to have co-payment about like 10% to 20%. This could be, it's not much, but for a patient with unemployment or drug abuse, this will be a huge burden for them to continue the TB care. So in this system, we provide no out-of-pocket expense, full cover. And for all of the medical expenses, and they're full reimbursement from TMP, from CDC, not from National Health Services. And so how are we going to integrate the system? Let's see. So this is the normal situation when doctor treating the patient and the public health doing the DOT. So once we got this result from the lab that this is an MDR-TB case, we will send the specimen to Central Research Lab, which belongs to CDC. And then the central lab will confirm the MDR-TB diagnosis, and then through the national network, the electronic-based network, it will send out a signal, MDR-TB alarm, to the treating hospital and also to the public health sector. So then the TMTC, the patient will be referred to TMTC, and then the TMTC team will provide the treatment, also DOTS plus together, and followed by the Central Research Lab to give us the final second-line drug test to adjust based on the test, we will adjust our treatment. And we have this quarterly meeting. So CDC, a board of panels, and a TMTC member every 3 months will get together. What are we doing? We do outcome analysis, we do consensus forming, experience sharing, case discussion, and also go through surgical evaluation. And it's really important to have political commitment because not every patient wants to be taken care of by TMTC. So first, we provide TMTC, which is free of charge, excellent care. And then we have this Communicable Disease Control Act. So if a patient with drug-resistant TB is still infectious, but does not want to comply with treatment, our government has this control, based on this Control Act, we can have police officer to lock this patient and send the patient to the designated hospital for quarantine. So let's see the outcome from what we have been doing. So this is published in January 2018. After establishing this TMTC was established in 2007. So from the first 5 years, you can see that we enrolled almost 700 patients, and our treatment success rate boost from 50% to 82%. We still have a pretty high mortality rate because, just as I mentioned, we are dealing with older patients with a lot of comorbidities. Our failure rate drops to 2.6, and the most important and most astonishingly is the loss to follow-up rate. We dropped from almost 30% to 3% right now. And this is not just a programmatic success. We can see that this success actually translates to epidemiology impact. So the number and prevalence of MDR-TB in Taiwan has dropped from in new patient and in retreatment patient. And also we can see that the proportion of MDR-TB among new and recurrent patients also drops dramatically. And let's talk about the care model of TMTC. What we going to do this? What are we trying to do? Provide care. So the core members of TMTC first will be the physician, and then the case manager, which is very unique in our system. And then the nursing staff, that's the nurses in the hospital. And lastly, our DOTS provider. So what the doctor does, so we design a regimen, and we manage adverse reaction, and we engage other specialties because sometimes people will have other comorbidities that require our colleagues' help. And we organize a clinical team to provide adequate support. And we monitor treatment, and we are responsible for the treatment outcome. Then the case manager. So case managers they're basically nurses, but their job is to be the focal person to connect between the patient and the healthcare worker, the public health system, etc. and they supervise the quality of dogs, and they monitor adverse reaction, they manage financial and psychosocial support, and they oversee the transition of care, meaning that when the patient is hospitalized initially, and then after a few weeks and maybe a few months, the patient is ready to go back to the community, and the transition of care is responsible to be overseen by the case manager. And they're also responsible to construct a complete network of care. As for the nursing staff at ward, these nurses can provide very stringent DOP, but with very flexible timing. So each tablet will be directly observed. But if the patient is not feeling well, then we can move the time frame a little bit later or move a little forward. So it's flexible timing, but always DOP. And we can provide around-the-clock observation because sometimes patients will feel sad or have emotional stress, maybe late at night. And the nursing staff at ward can observe that and provide care and help. And also they can grab every opportunity to provide a continuous health education and also emotional support. And also a unique part to this program will be the DOS provider, because the DOS provider was sent from the hospital, directly from the hospital, but not from healthcare workers. So we rent cars and we drive the car to the patient's house or the patient's workplace to provide flexible and supportive DOP. So we have this tablets, and it's written what kind of drugs, how many tablets, and also we promote the detection of patient's problem, because problem detection, because sometimes patients, they don't know what problem they have. So based on our past experiences, our DOS provider has detected a patient who just had a stroke, because when they come to see him and they saw this saliva streaming from his mouth, and they immediately send him back to our ER. And they have timely response to the patient's need. They can also get them like food vouchers or have them like food lunch boxes. And they have an in-depth understanding of the patient's life, because sometimes patients will not tell you every details in their house. But by visiting their house on a daily basis, we get to know what happened around them. And also sometimes the patient will receive the most traumatic stigma or being discriminated by their family members or their society. At this time, or their community, the DOS provider could be a very good supporting bridge and to trying to give them the right attitude and trying to support the patient. So by doing this, we summarize this, and we have a different phase of care. The first is like MDR diagnosis, pre-enrollment, and then after the diagnosis, we'll be enrolled into TNPC care. And then we strongly suggest initial hospitalization, and then we will move to community care. Some people will still remain in hospital-based, but the majority of our patients will go back to their community and until treatment completion. So what we're doing, the first stage, before we start MDR treatment, we need to know what we're fighting for. First, we know the bacteriological result. We need to get ready, because it's a long way to complete the treatment. We really need to get ready before we start. And we need to obtain the previous TB treatment records, which could be done by the national electronic-based system. We need to know the epidemiological information, comorbidity evaluation, and also know the psychosocial and financial constraints about the patient, so that we can really design a treatment and support that is suitable for the patient. And during their enrollment time, the doctor and the case manager will talk to the patient and the family. We're trying to form a consensus, a strategic consensus. We're trying to provide initial counseling, and also by talking about family lives and personal lives, we are doing the basic contact investigation, also risk evaluation. And once the patient was hospitalized, we're started our full engagement, and we're at war. So we do drug ramping, and ADR management, comorbidity, like taking care of their diabetes, trying to deal with their alcoholic abuse, and establish rapport and trust, because every patient will have one or more than one adverse effect. By doing this, by providing care, we can establish rapport and trust. And finally, when they go back to their community, it's a marathon of care, because people get frustrated sometimes because they are looking toward the end of the treatment. It's like 18 months away. It's like a long, long time ago. So they need to be supported, and also trying to remove their stigma. So if we have time, we can do some case sharing. First case is lost to follow-up. This is a 32 married man, and he has no kids. As we can see that there is some haziness about his right upper lung infiltration. He's a smoker, he has history of family abuse, and is heavily addicted to online video games. So during his job interview, this is a job application, so he needs to go through, he needed to go through the X-ray screen, but the X-ray report was abnormal. So he was notified to be a TB patient in June 2010 and started TB treatment, the first line TB treatment. However, a few months later, we know that the culture came back and it was actually drug-resistant TB. So he was transferred to my hospital and hospitalized in October 2010 for drug ramping and initiation of MDR TB treatment. And he actually moved his computer to this negative pressure room because he is so addicted to online games. And he was successfully discharged 1 month later after drug ramping. However, just 2 months after his discharge, we noticed, because every day we sent the DOT provider to his house, we can notice episodes of non-adherence. It started from like once in a month and then maybe twice in a week. So we stopped the TB treatment because we noticed there was a pattern that he is not going to comply and to adhere. So after talking to him, we stopped TB treatment and we repeat sputum workup. And also in the meantime, we didn't mean to give him up. So we contacted a health authority, and based on the Communicable Disease Control Act, we asked the police officer to go to his house and grab him and send him to another TNTC allied hospital. That's way up south, way in south. So it's in southern Taiwan, which is away from his home. It's not easy for him to escape, and he was mandatory hospitalized there for 4 months. And this time he knew that we really want him to be cured, and there is no way he can escape from the system, and we need him to be responsible for his treatment. So after 4 months, he became very compliant, and he was applied for TNTC enrollment again. He was sent back to his home and under our care with good adherence, because we promised we would give him some financial support. So we're able to cure him in September 2012. So in this case, the success is because we have prompt detection of non-adherence by our DOTS provider, and we have a supported public health authority who are willing to mobilize the Control Act and find the police officer to help. And we have financial support from our government funding, and also we have the help from our LITNTC hospital. And the second case is a little bit more complicated. It's a treatment after failure patient. This is a 43-year-old woman, and she had been a widow for 10 years, and she had 2 sons. She reported no underlying diseases, and she had no substance abuse. But even though she had no diabetes, no hypertension, she did have a very impressive TB history. She had underwent 3 courses of TB treatment in the past. And in September 2008, she was registered as a TB patient for the 4th time. And as you can see, if a patient has undergone like TB treatment again and again and again, this is a high-risk group for drug-resistant TB. And this time, she did have the culture positive and confirmed to be MDR TB and referred to my hospital in October 2008. And just based on what we have shared before, we strongly recommend initial hospitalization, because we always we know that there's always going to be a lot of side effects, and there's no way we can deal with the side effects with a retreatment patient. However, she refused to be admitted, so she insists that she will start the treatment while staying in the community. So we started treatment starting from her body weight is like 47, and she was smear positive and culture positive at that time. Her second line DST was okay, but all of the second line drugs are susceptible, except that she was resistant to Reviono, which is understandable. And we start treating her on second line drugs. And her X-ray right now on the right-hand side is a severe TB cases with a cavity formings and a lot of destruction of both of her lungs. But after a few months of treatment, her X-ray improved and her sputum culture got converted. And she had a dramatic body weight increase to like 9 kilograms to 56 kilo right now. And however, several months later, like month 6 to 7, she continued to gain weight, but I'm not so sure about the X-ray presentation because it seems to me that the X-ray got a little bit progressed, especially on the left lungs. There seemed to be new cavities forming. She also reported nausea and vomiting, but she denied it. She had any pill missing, and she continues to do fine. By month 10, this time, she continued to gain weight, 2 more kilos, but her X-ray was definitely got worse, and the new cavity on the right upper lungs, and she also had fever and worse productive cough. So I was very sure that we're dealing with a treatment failure right now. So we repeat the student workup, but she still refused to be hospitalized at that time. So by month 11, now everybody can see that the X-ray was really bad, and she started to lose weight again. And her student culture back in month 10 came back positive for culture. So we are now sending the culture for second-line drug, and we're now knowing that we are dealing with a treatment failure after MDR-TB treatment. So month 12, we got the second-line drug result back. There is no new required resistance. However, the X-ray was not good. So we declared treatment failure after 1 year of hard work. But this time we're just we stop and think that what might be the possible causes to this treatment failure. The first will be DOT, because she was not under the DOT by the DOS provider from our hospital because she lives far away. So the DOT was actually provided by the healthcare system, and she might have a way to escape from their supervision. And also she got financial constraint. She has to work and she has to support her sons, and she has no one to count on, so there was a very weak support system. And she also felt depressed all the time. And maybe I strongly suspect that how can a patient keep gaining weight while the X-ray is getting worse? So we strongly doubted that there might be some corticosteroid exposure. So our plan is we hold all the treatment adjustment, we need to contact her sons, and we need to ask her son's help to convince their mom to be hospitalized. So once we reached out her sons, this time from February, we started a second round of treatment. And this will be the 5th round of TB treatment and the 2nd round of MDR TB treatment. It was hospitalized way through until the treatment completion. And we monitored the DST change. And yes, we did found a lot of steroid pills in her house, and a lot of TB pills also. So from this period of time, we knew that this time we got the new second-line drugs, DST back. We now have resistance to fluoxetine. For TB doctors, we know that we're now treating not just MDR TB, but pre-XDR TB. So we made another adjustment of the treatment, and we're able to have student conversion after 2 months of treatment. And this is a very hard treatment for her and for the team. This is her leg. You can see the scaling of her skin is from side effects of clofazimine, and she also had hypothyroidism, anemia from linezolid, and hepatitis. It's very difficult. And also we realized once she was hospitalized, we realized that she had some psychiatric issues. She became irritable sometimes, even had erotic delusion. Finally, we called in the help from psychiatrists, and we got the diagnosis of hypomania. Eventually, we did cure her, and she was discharged in November 2011. So the case success is thanks to the engagement of their family members, her sons, and supportive healthcare system, financial support, and our nursing staff, and also comorbidity management. So my conclusion will be, this is the phase of our care, and it should be patient-centered care. No matter what phase we're in, it's always patient-centered. And we should look for a seamless transition. Whether the patient is in the hospital or in the community, there is a seamless transition. And we need to have a holistic approach, because we are not just treating their TB, we're also providing care and support to their house, to their family members, and it's individualized support. Some patients need some financial support, some patients need someone to talk to, so everybody's different. So the recipe for success, how can we build is to build a GRTB program that functions. By functions, I mean integration of system and administrative maneuvers. So integration of the system, we're integrating public health and private health, drug susceptible and drug resistant TB, and also we integrate TB and general health because all the TMTC hospital are actually general hospitals. So it's not just TB specific hospital. We also have like surgery, have pediatric, we have all other facilities and medical disciplinary in the hospital. Then we also integrated MDR-TB treatment with DOTS Plus. As for administrative maneuvers, we have mandatory reporting, which is very important. And through the electronic-based system, we can pretty much get a good idea about how many patients we're treating and what their treatment outcome was. And we also have legal action and surveillance. And plus, we have very stable second-line drug supply and restriction. By restriction, we mean that we have a restriction on the use of fluoroquinolone to treat drug susceptible TB because we don't want other treating physicians to overuse the fluoroquinolone in a not safe way, so that we will create more fluoroquinolone resistance in the future. And also the system has to sustain, so we have financial support from our government. And lastly, the system has to grow. So it's a teamwork. As long as the team members involved can continue to work together, then the system will grow. My final conclusion, where there is a political will, there is a way. So I believe that the Taiwan CDC made a tremendous effort in establishing the system, and that is the only reason that we can see the improved quality of care right now in Taiwan. And this actually, suppose that the previous one would be my last slide, but because we're talking about COVID-19 right now, so my last slide will be this one. But TB program helped in the fight of COVID-19 in Taiwan. And for the TB society, we learned a very hard lesson during SARS period in 2003, because we don't know what to do with that. We need to allocate our patient. Where are we going to send our patient? How many negative pressure rooms we have? So we learned a very hard lesson. So this time, the TB program helped in some way. First will be preparedness. We learned how to do this resource allocation. By resource, I mean like negative pressure rooms, masks, and like protective gowns and everything. We have routine training of healthcare workers. Ever since SARS, we have this routine drill for healthcare workers. We just do this protective gown and mask and everything. We do this training every year just to be prepared. One day there might be another wave of new infectious disease coming. And also we have this thorough contact tracing, because we have done this contact tracing for a long time for TB patients. So now, borrowed from the contact tracing techniques, we are able to track down our COVID-19 patients and their contacts. And also the rapid responsiveness. The TB program has used molecular diagnosis, for example, like Gene Expert. So it's common for us right now. The Gene Expert machine can actually be adopted and used for COVID-19 diagnosis. So the laboratory facility can have the capacity to perform timely diagnosis. And second, we do this integration of healthcare service. So within the hospital, we managed to move out the negative pressure room and to allocate the hospital beds. And we also integrate the hospital with other healthcare facilities and also across government departments. It's all being done through the electronic-based management. For example, if a TB patient is smear positive and they're trying to fly out of Taiwan, and then the border control of Taiwan will have a direct electronic link with our national surveillance system. So the patient will be stopped at the border. And same reason. So when everyone trying to get into Taiwan, and the border control will also have this direct link with the national health insurance system. So we can know by the national insurance card, we can identify patients just being into foreign countries within the past 14 days. And lastly, the transition from hospital-based and community-based. So we try to move more TB patients to the community-based care, and trying to evacuate our hospital beds to take care of the COVID-19 patients. And most importantly, I think it's very important to provide emotional support and stigma elimination. Most of the COVID-19 patients, when they're hospitalized and quarantined inside the negative pressure room, they could be very lonely. And somehow the viral load seems to continue to detect the viral load for quite some time. We've had patients being quarantined for more than 1 month, 30 days or 35 days. And it's the same group of people, I mean, especially the negative pressure room nursing staff. They're the same group of people who has been taking care of TB patients all the time. So they knew how important it is to provide emotional support and trying to eliminate the stigma for those patients in need. So this is my final slide, and this is a map of Taiwan, and the red arrow there was my team, and we also have 4 other TNPC teams together. I'm very honored to be one of them, and also it's my great pleasure to share our response with you. Thank you.
Thank you. That's the wonderful presentation from Dr. Rebecca. So give applause one more time to talk about management of MDR TB in Taiwan. All right then, so to comprehend our understanding about the presentation, we will go directly open the...
Sorry, I can't hear you.
Now we will go to the question and answer session, Mom. Is that okay?
Yes,
okay.
yes.
Okay. Now all right. Now I will invite all webinar participants to join the question and answer session. And then I'd like to invite also the audience here if you have any questions. So please just participate in the question and answer session. Is there any? Right. Okay. Mom, please introduce yourself before you deliver your questions.
Okay. Thank you. Good afternoon, Miss Rebecca. My name is Tristanti. I come from UMKU, Universitas Muhammadiyah Kudus, Indonesia.
Yes.
Thank you. There are a lot of TB cases in Indonesia in the world. Maybe, I'm sorry. Maybe my question is out of MDR TB cases, but I think it's still related with TB cases. This is about underreporting case of TB. We know that underreporting case of TB is still high. Can you give the suggestion how to solve the underreporting TB cases? Thank you, ma'am.
Right. If I can repeat the question is, there are so many underreporting cases of tuberculosis in the global. Then the question is, how can we minimize the underreporting case of tuberculosis? So that was the question. Would you please give the answer, doctor?
I think it's a very important question, especially for high burden countries like Indonesia. And by underreporting, it has different problems when we talk about underreporting. First, do we find the patient? So sometimes we haven't found the patient yet, so it's like under-detected. And sometimes we detect the patient, but we fail to report. That's another failure in underreporting. So I think we can look at this problem in 2 different ways. First will be under-detection. I think we need to do more in terms of case detection. And traditionally, we really, it depends on the national policy. I don't know whether in Indonesia, whether you depend on symptom screening or like high-risk group screening, because most of the time, TB patients are very vulnerable. So it is hard for them to have health access. So we need to have a local epidemiological data for you to understand what are the majority of your undetected patients, understand their characteristics, so that in order for you to identify them. For example, you might find a lot of TB patients among your diabetic clinic. You might also find a lot of TB patients in your general hospital when they're hospitalized for other reasons. So the important thing is how we are going to integrate our current diagnostic tests to detect those patients. I know that most of the countries right now, especially WHO, we're aiming for rolling the rapid molecular diagnosis like expert. But it's not easy for everyone or every place to have expert. So we still have our very good old friends like sputum smear and especially chest X-ray. To combine these modalities, I think you can have a better understanding and better strategy to identify those patients. And very importantly, you really have to keep track in your TB program. Once you diagnose the TB patient, are the patient report. So if you fail to report, then you have this underreporting or pre-treatment loss to follow up, then we really need to have an administrative strategy to minimize this pre-treatment loss. So that's my suggestion to you. I'm not sure if I give you enough suggestion, but yeah, please feel free to ask me if you need more of my opinion.
Right, that was the amazing explanation from Dr. Rebecca toward the question. To Ibu Ika Tristanti, does it answer the questions?
Yeah, thank you, Madam.
Okay, thank you. And moving to the another question, is there any chat room questions? All right, we still have about 2 or 3 questions, Mom. So, okay, let me show me, okay, the chat room questions. Right, okay. So the question from Muzamil, the question is, how the challenge from higher education in the industrial revolution era 4.0, especially in the pharmaceutical sector, in the middle of the COVID-19 pandemic. One more time. How the challenge for higher education in industrial revolution era 4.0, especially in the pharmaceutical sector in the middle of the COVID-19 pandemic. So that's the question, Mom.
I'm not sure I can answer this question because it's just something about how the challenges for higher education in the industrial revolution.
Right. Yes.
Pharmaceutical sector. So I don't think this is, I'm not sure this is my expertise because I don't know whether this question is related to TB control. Is this question reserved for Professor Liao before? Or
okay, maybe if you have any suggestions for the higher educations, so tell us about a little bit challenge or suggestions in a pharmaceutical export. If you can give your suggestions about this situation in the pandemic COVID-19.
Pharmaceutical sector.
Yeah, pharmaceutical sector. If you have any recommendation or suggestions, but if you have done any, it's all right.
Yeah, I'm sorry, but I don't think I can give you any recommendation regarding pharmaceutical sector.
Okay, Mom. Okay, so maybe we are moving to the another question, please. Do we still have another question from the chat room? Is there any?
No.
Is there any? Okay. Okay.
没有，他只是叫他们有问题可以举手。
有人举手。
只是有问题可以举手。
哦，好。
Is there any more questions? The audience here, please participate for the question and answer session to the presentation from Dr. Yes?
没有，有现场的，他们现场。
对，要后面这个人有很多人一起参与。
真的有人举手，都看不到手。
他没有招到他们进来。
All right then. Mom, seems like we have no more questions about this discussion. Then we would like to say thank you one more time for Dr. Rebecca Chou-Jui Lin for the wonderful presentation talking about management of MDR TB in Taiwan. But before I close this session, would you please give a closing statement, ma'am, please?
It's my great honor to share our experience with you. And just like Professor Liao has said, those infectious diseases like COVID-19 and like TB, they know no borders. So it's very important for us as global community to fight these diseases together. So it will be my great honor if we can provide any help. Just please let us know.
Okay, so thank you very much once again to Dr. Rebecca. Yeah, we are really amazing to have an expert speaker to talk about tuberculosis and COVID-19. But I must end this session. Thank you very much to the Dr. Rebecca one more time. And I will turn it back to a Master of Ceremony, please.
Okay, thank you, Mr. Syafiq. Ladies and gentlemen, the next agenda is video from Taiwan International Healthcare Training Center. Please enjoy.
Over the past 50 years, Taiwan experienced economic boom that transitioned Taiwan's role from a recipient country to donor country. Now Taiwan is one of the advanced countries in the world in medical and healthcare technologies. In 1995, we successfully implemented the mandatory National Health Insurance Program with 99.8% coverage rate, with an expenditure of only 6.6% of GDP. This has brought about significant improvements in the health of the 23 million citizens in Taiwan. In 2016, the United Nations announced the Sustainable Development Goals for 2030. As a global citizen, Taiwan must play an integral part in the pursuit of sustainable development in the world. On international healthcare issues, Taiwan is both willing and able to work together with the international community in formulating future development strategies. 15 years ago, Taiwan initiated plans to proactively share its advanced medical technology and resources. Thus, the Taiwan International Healthcare Training Center was established. Under the Ministry of Health and Welfare and executed by Taipei Hospital, the center must carry out international health cooperation and aid. The Taiwan International Healthcare Training Center is responsible for the training of international healthcare personnel and hosts international academic conferences, as well as provide international clinical services and assist in international emergency rescue missions. By the unwavered efforts of Ministry of Health and Welfare and Taipei Hospital, the center received the Bronze Award of 2012 National Biotechnology and Medical Care Quality Award. Moreover, in 2016, the center won the first International Medical Model Prize Group Award. In the era of globalization and increasing awareness of humanitarianism, international healthcare collaboration is the key to eradicate health inequality around the world. Governmental and non-governmental institutions around the world recognize that access to healthcare is one of the most basic human rights. Healthcare personnel around the world now share common responsibilities as contributors, and TIHTC in Taiwan is the platform for like-minded, compassionate professionals like yourself. Not to mention, the center provides accommodation and offers comprehensive care to host all of our distinguished guests and trainees. On behalf of the Taiwan International Healthcare Training Center, we sincerely welcome prospective participants to join our world-class educational programs. As we nurture partnerships between health workers around the globe, our center shares the tools to better build health systems worldwide and to empower professionals like you. Since 2002, the Taiwan International Healthcare Training Center has provided clinical and healthcare management courses to nearly 1,500 professionals from 60 countries. Continuing education and hands-on training help the center's participants develop their skills and stay abreast of the latest medical developments so that they are prepared for new healthcare challenges in their homelands. Furthermore, the center has partnered with 30 hospitals across Taiwan to conduct world-class training led by outstanding and dedicated professionals from top healthcare institutions. Taiwan is also known as Formosa, meaning beautiful island. The diversity of Taiwan's culture and heritage is the integration of different ethnic groups and illustrates the harmony and prosperity possible among various religions, architecture, languages, lifestyles, and cuisines. The world-renowned Taipei 101 Tower is also known as the Taipei Financial Center. It is the landmark skyscraper located in Taipei. There are more than 300 night markets in Taiwan, where you can experience the various tasty traditional Taiwanese snacks. Just like the proverb, teach a man to fish and you will feed him for life. The Taiwan International Healthcare Training Center seeks to develop the foundations of self-sufficient health services as well as improve the overall quality of life for our international partners.
Good day, I am Dr. S.Kp.M.Kep, the Superintendent of Taipei Hospital. On behalf of the Taiwan International Healthcare Training Center, TIHTC, Taipei Hospital, I would like to extend my warmest welcome to all of you. During the past 18 years, over 1,600 medical professionals from 68 countries have received training through TIHTC. Now, the center is training over 100 international medical health and administration personnel per year and is regarded as the co-international cooperation unit of Taipei Hospital. This year, due to the COVID-19, TIHTC have moved the project training programs online. Now, medical professionals around the world can continue to further their medical training through the online platform without being affected by the pandemic. Taipei Hospital and TIHTC, we continue to provide tailored project training courses and work hand in hand with medical institutions to develop international healthcare talents. These courses and exchanges will play a contributing role in improving the medical standards and public health promotion in all corners of the world. As an international healthcare training institution, we are proud to announce that 2020 online project training programs are now officially open.
TIHTC welcomes you on board to improve health for all. Yay!
In this joyous occasion, the Taiwan International Healthcare Training Center would like to thank you for all your support. We look forward to seeing you. Join Taiwan and be a contributor.
Yeah. Nice.
One more time, give big applause to Taiwan International Training Health Center for supporting this conference.
Now we move to session 4, the presentation from Professor Dr. Reviono, Consultant of Pulmonary Specialist, the Dean of Medical Faculty, Universitas Sebelas Maret. Will be guided by Mr. Ahmad Nur Syafiq, Master of Education. The floor is yours.
Thank you, Mr. Master of Ceremony. Well, ladies and gentlemen, now we are moving to session 4, the presentation from Professor Dr. Reviono. He will talk about tuberculosis during COVID-19 pandemic. And then to save our time now, I will keep in touch with Professor Reviono.
Yeah.
Hello, Professor. Assalamualaikum.
Waalaikumsalam warahmatullahi wabarakatuh. Good afternoon.
Okay, show the picture of Professor, please.
Yes, me.
Okay. Okay. Right, Professor, before you deliver your presentation, maybe we will have a photo session together, right?
Okay, yeah.
Okay. Okay, now please, I invite all the participants of this webinar to join the photo session. Please come to stage.
Okay.
Prof. Raffi, ini kita pada foto sesi dulu, sesi foto bersama dulu.
Yeah. Okay.
Right. Okay. 1, 2, 3. Again. 1, 2, 3. Freestyle now. Freestyle. 1, 2, 3. One more time. 1, 2, 3. Okay. Thank you very much. Well, ladies and gentlemen, in the session 4, the presentation will be delivered by Professor Dr. Reviono, consultant of tuberculosis, pulmonary tuberculosis.
Yeah.
But before he delivers the wonderful presentations, let me introduce him for a while. Okay, his full name is Dr. Reviono, Professor Dr. Reviono. And then he was born in Bojonegoro, 30 of October 1964. Okay.
Right there.
And then now he works as a KSM Paru RSUD Dr. Muwadi. Leres nggih, Pak?
Yeah.
Okay.
Muwadi, yeah.
And then now, right, he is also the Dean of, all right, then Fakultas of Kedokteran UNS. About his educational background, right, now he is a doctoral degree of Medicine Faculty of UNER 2011. He is also a consultant of lung specialist, lung specialist, right? So he is a glance of his curriculum vitae, and then to save our time, we will go directly for the presentation. Professor, now the floor is yours.
Okay, thank you. Thank you. I'd like to thank you for committee who have invited me. And may I share the presentation PPT? Okay. Okay, the presentation today is the title Tuberculosis during the COVID pandemic. I present will in mixed language, yeah, Indonesian and English, and
yes.
maybe, yeah, maybe I'm comfortable for any bahasa maybe. Yeah. Okay, we know the recent emergence and rapid global spread of SARS-CoV-2 and the resulting coronavirus disease 19, and we call COVID-19, poses an unprecedented health crisis that was declared a pandemic by the World Health Organization. No one predicted the impact of pandemic as of today. Tidak ada yang menyangka bahwa akibatnya seperti ini. The virus has nearly every country worldwide, to maybe less than 6 months to every country. Tuberculosis remain tuberculosis remain a global health emergency, and needs our attention more than ever. Given that significant resources are now being diverted to COVID-19. What about TB? Yeah. What about tuberculosis when COVID-19 is so front and center globally? Clearly, TB has not disappeared, but does anyone still care? I think it's not clear TB. There is no policy changes in TB control. And if so, are we able to do more than what as an existing global health problems becomes increasingly neglected, leading to predictable outcomes? Okay, before talking about the COVID-19 and TB pandemic, we will first discuss the COVID-19. Ya. Jadi mungkin saya harus menjelaskan tentang COVID-19 secara patogenesis, bagaimana menginfeksi. This is a genome of SARS-CoV-2. The structure protein include spike, protein spikes, envelope, membrane, and nucleocapsid phosphoprotein. In the interior of virus is RNA genome. Ya, jadi ini materi genetik penting yang disebut RNA genome. RNA genome ini nanti akan masuk ke dalam sel host untuk bereplikasi, untuk membelah, memperbanyak diri, sehingga dia nanti akan bertranslasi ya bertranskripsi menjadi virus baru. Jadi bagaimana ya, RNA genom ini membelah di dalam tubuh host, itulah yang dibutuhkan virus. Salah satu persyaratannya adalah harus ada reseptor. That's important. The cell host have a receptor. The receptor is S2 receptor, ya, expression. S2 reseptor ini banyak macamnya. Ya, ada di makrofag, ada di epithelial cell, ada di mikroglia. Mikroglia itu sel saraf, juga neuron sel di saraf. Tempat-tempat ini bisa dimasuki oleh virus SARS-CoV-2. This is pathogenesis. How to SARS-CoV-2 enter to the cell host and then replication, multiplication, and membentuk virion, membentuk virus baru. Jadi yang pertama, virus ini harus ada reseptor. Ini gambar reseptor, warnanya merah. Dan protein yang penting adalah spike protein attach in the receptor, and then after that proses membran fusion. Ya, setelah masuk virusnya pas, proteinnya pas dengan reseptor, akan terjadi membran fusion dan kemudian endositosis. Nah, ini RNA inilah yang masuk ke dalam sel. Ya. RNA ini kemudian bertranslasi, membelah, membuat suatu protein, namanya translasi membuat protein. Proteinnya ini tadi, spike protein atau protein S, envelope, membran, nukleokapsid, adalah protein-protein struktural virus. Tapi juga dia dengan fungsi virus itu sendiri juga akan ditranslasi, akan bentuk. Nah, ini akhirnya membentuk virion atau bakal virus ini. Kemudian virion ini nanti keluar ke dalam tubuh membentuk virus baru. Nah, dalam proses ketika virus ini masuk ke dalam sel host ini tidak diam. Sel host ini bereaksi, berespon untuk berusaha menghilangkan virus ini. Sehingga dipanggil juga sel-sel inflamasi. Tapi sebelum itu, saya mungkin akan sampaikan bahwa S2 expression in the many organ, the brain, lungs, kidney, vasculature, intestine, liver, heart, banyak organ yang bisa dimasuki oleh virus COVID-19. Di sini ada gradasi tinggi pada warna merah dan sebagainya. Ternyata virus yang paling tinggi, reseptor yang paling tinggi ada di intestine. Makanya gejala ada mual, mutah pada pasien COVID-19. Ya, tapi yang mudah dijangkau adalah di paru ataupun di saluran napas atas. Saya melanjutkan proses infeksi tadi. Demikian SARS-CoV-2 masuk ke dalam sel tubuh. Ini contohnya. For example, cell dendritic, macrophage, and they respond with secretion chemokine, cytokine, and the cytokine, chemokine, and also complement will secrete the cytokine, and then cytokine attract the inflammation cellular, akan menarik sel-sel lain ke dalam lokasi infeksi tadi. Jadi akhirnya ada sel-sel seperti sel limfosit, seperti sel-sel dendrit, Nah, ini tertarik ke dalam tempat infeksi, berusaha untuk mengeluarkan virus. Nah, sel-sel inflamasi ini juga akan kembali mengeluarkan sitokin, kemokin juga, karena dia memang bisa memproduksi. Akhirnya semakin banyak lagi sel-sel yang terlibat, menarik makrofag, menarik dendrit, menarik neutrofil, basofil, dan sebagainya. Dan sel-sel yang baru ditarik ini mensekresi lagi sitokin-sitokin. Demikian sehingga menjadi besar. Nah, ini apa yang disebut dengan sitokin storm tadi. Karena begitu banyaknya sitokin yang diproduksi. Nah, sitokin storm inilah yang berbahaya. Dia bisa merusak sel-sel di paru, dan secara tidak langsung inilah yang menyebabkan kematian. Jadi ini yang pertama, ketika saya ulang tadi, patogenesis awal, ketika SARS-CoV-2 masuk ke dalam seseorang, di sini akan ditangkap salah satunya misalnya selnya adalah monosit atau makrofag, kemudian makrofag teraktivasi, mengeluarkan sitokin tadi. Ternyata dalam kenyataannya, yang kita amati, ada yang ringan, mild, ada yang severe di dalam tubuh itu. There is depend on the response of immune. The normal immune response is still the mild, gejala yang ringan. Ya. Tapi kalau yang responnya tidak terkontrol, akan menyebabkan gejala yang berat. Ini salah satu faktor, adalah respon imun dari tubuh itu sendiri. Ada yang normal, merespon sewajarnya, tapi ada yang berlebihan. Yang berlebihan inilah yang menyebabkan apa yang disebut sitokin storm. Nah, ini adalah penyebab tidak langsung. Kemudian penyebab kedua selain respon adalah highly pathogenic dan low pathogenic. Jadi virus itu ternyata ada dua. Jadi yang low pathogenic maupun yang virus patogenik. Ini sebenarnya melanjutkan dari gambar yang sebelumnya, bahwa ini adalah suatu gambaran beratnya penyakit. Beratnya penyakit ini bawah yang ringan, ke atas semakin berat. Awalnya adalah seperti ini mestinya. Jadi virus direspon secukupnya. Ini yang disebut early infection. This is a mild constitutional symptom, like a fever, dry cough, maybe lymphopenia. And then if the host higher response, akan menyebabkan gejala yang lebih berat. Kalau stage 1 tidak teratasi, maka akan masuk ke stage 2. Stage kedua ini pulmonary fase. Jadi yang awalnya stage ringan ini apa yang disebut dengan orang tanpa gejala ataupun gejala ringan, biasanya hilangnya bau mungkin atau sekedar nyeri tenggorokan. Tapi kalau sudah masuk pulmonary fase, di sini sudah ada batuk dan sesak napas. Nah, ini mulai ada sesak napas. Nah, ini yang mulai ada perubahan-perubahan pada laboratorium dan menyebabkan abnormal fotoronsen. Kemudian juga hal-hal yang lain seperti koagulasi dan sebagainya. Nah, ini penentuannya di sini. Apabila tubuh tidak bisa mengendalikan dengan baik, akan muncul yang disebut hyperinflammation fase. Ini yang cytokine storm ada di sini, sehingga terjadi acute respiratory distress syndrome atau ARDS, SIRS. Ini beberapa parameter, elevated inflammatory markers like CRP, C-reactive protein, LDH, interleukin 6, D-dimer, ferritin, and so on. Ini adalah marker-marker kalau terdeteksi tinggi, ini berarti stage 3 dan berarti kondisi buruk. Nah, karena di sini saya harus presentasi tentang tuberkulosis yang pada masa pandemi, saya juga akan menyampaikan dengan patogenesis tuberkulosis. Ini adalah basil tuberkulosis. Basil tuberkulosis juga harus ada reseptor yang cocok. Yang cocok itu adalah ada di alveolar makrofag. alveolar makrofag di sini namanya makrofag manus reseptor. Tuberkulosis nempel di sini sehingga akan menginfeksi, dia akan masuk ke dalam sel makrofag. Jadi ini kalau tadi virus gambarnya bulat, kalau tuberkulosis gambarnya batang panjang, di sini dia masuk ke makrofag. Nah ini kalau tidak bisa merespon tubuh, akan terjadi bakteremia. Bakteremia with seeding of multiple sites. Dia akan menyebar ke seluruh tubuh. Tapi kalau ini bisa teratasi, ini patogenesisnya seperti ini. Jadi yang pertama, microtuberculosis antigen will serve with class 2 MHC, dari mayor histocompatibility, yang cocok dipresentasikan ke sel T. Nah, sel T akan berubah menjadi sel TH1, kemudian mempunyai respon yang spesifik. Ya. Jadi setelah Mycobacterium tuberculosis enter macrophage by endocytosis mediated by several macrophage receptor, and then inside the macrophage Mycobacterium tuberculosis replicate. Nah, kemudian setelah teraktivasi macrophage ini berusaha untuk memblocking atau mencegah penyebaran apa yang disebut dengan granuloma. Jadi ini kalau respon imunnya baik, dia akan dalam granuloma dikitari oleh sel-sel inflamasi seperti limfosit, seperti makrofag dan sebagainya. Ini gambarnya sama dengan tadi, pathogenesis. The first is inhalation of Mycobacterium tuberculosis, and the evidence is phagocytosis of bacilli. Yeah. But if the host can eliminate the Mycobacterium tuberculosis, the inflammatory cell recruitment. Alveolar macrophage secreted interleukin 12 and interleukin 18. And then also interferon gamma induced bacterial killing. And TNF-alpha is essential in the control of Mycobacterium tuberculosis growth and granuloma formation. Jadi persyaratan ini harus ada. Tubuh harus bisa mensekresi sitokin-sitokin ini agar terjadi control of Mycobacterium growth, stop Mycobacterium tuberculosis proliferation, and then secretion of the chronic cytokine stimulation. Granuloma is formed by several cells recruited to the lung inside infected macrophage content of Mycobacterium tuberculosis, preventing their spread. Jadi ini persyaratan agar tuberkulosis tidak menyebar. Itu harus terbentuk yang disebut dengan cell mediated imun. Ini gambarnya ini masih sama, tapi ini mungkin sedikit ada epidemiologi. Bagaimana ketika Mycobacterium ini masuk ditangkap tadi ya di dalam makrofag. Ini gambar makrofag. Nah, kemudian tadi harus ada tubuh harus bisa memproduksi interferon gamma, TNF-alpha dan sebagainya dalam usaha untuk mengeliminasi atau paling tidak containment. Jadi basil tuberkulosis itu ada di dalam tubuh kita sebenarnya. Ketika kita tertular pertama kali, tapi kita tidak sadar karena di Indonesia ini sebenarnya tuberkulosis endemik, sumber penularannya tidak diketahui. Nah, ini pasti dalam tubuh kita sebenarnya ada. Cuma kalau pertahanan kita baik, akan terjadi containment, akan bisa ditahan penyebarannya. Nah, kemudian ini yang berhasil, tetapi nanti orang-orang ini dalam perjalanan, kalau bisa saja dia reaktivasi kondisi lemah seperti ada komorbid, seperti diabetes mellitus ataupun ginjal, dia akan terjadi reaktivasi. Jadi yang Mycobacterium tuberculosis yang ada di granuloma ini bisa bangkit kembali, kemudian menjadi TB aktif. Atau juga bisa sebenarnya dia tidak reaktivasi, kondisinya misalnya baik-baik saja, tapi dia terinfeksi oleh Bacterium tuberculosis yang strain baru. Ini juga bisa menimbulkan tuberkulosis, ini yang disebut dengan post primer. atau yang TB yang pengertian kita saat ini yang diterapi adalah yang posisi di sini. Kalau yang di sini biasanya kita tidak tahu, hanya bisa dideteksi dengan sel mantuk, itu mantuk tes positif itu ada di sini, tapi tidak diobati biasanya di sini. Di sinilah baru problem-problem ini. Nah, biasanya tetap bisa sembuh spontan sebenarnya bisa, tapi ada juga yang memang harus diobati. Nah, ini seperti dengan COVID-19, tuberkulosis juga bisa di luar paru. Sebagian besar memang 85% ada di paru, tapi ada juga di luar paru, ya seperti COVID-19 tadi, ada di kelenjar getah bening, ada di genitorio tract, ya, ada di TB tulang, TB selaput otak, intestine dan sebagainya. Nah, ini gambaran TB. Kalau yang di sini adalah waktu, kalau yang di sana ini adalah beratnya penyakit. Jadi ini biasanya kondisi klinis TB ditentukan oleh balance antara sel T dan bacillary burden. Jadi jumlahnya. Kalau kondisi ini adalah kondisi aman, jadi sel T-nya ada di atas, bacillary-nya ada di bawah. Ini yang disebut dengan TB laten, seperti yang saya sampaikan tadi, containment ada di sini. Jadi ini TB laten. Kita mungkin ada di TB laten. Nah, suatu saat bisa reactivation atau reinfection. Kalau ini burden-nya di atas, terus kemudian justru sel T responnya menurun karena terinfeksi TB, ini yang disebut dengan VA advance atau gejala berat. Tapi kalau tubuh bisa responnya turun sebentar, jadi minimale, kemudian basilnya naik sedikit, ini yang TB minimal, TB paru dengan lesi minimal. Nah, sekarang similarity and difference between COVID-19 and tuberculosis. Differences, yang pertama perbedaannya. COVID-19 dan tuberculosis. Perbedaannya onset COVID-19 acute, tuberculosis chronic. Transmission, COVID-19 droplet transmission and by touching, yeah. And maybe airborne is still debated, but the tuberculosis airborne transmission is evidence, and also by inhalation. The pathogen, COVID-19 is viral disease, SARS-CoV-2, and tuberculosis is Mycobacterium tuberculosis, is bacteria. Incubation period, yeah, exposure to disease, COVID-19 short, only 5 to 14 days, but tuberculosis longer, more than 2 weeks. Yeah, more than 2 weeks. I think it's yes, maybe about 2 months or more. And clinical feature, COVID-19 having more commonly a dry at presentation, a dry. But tuberculosis is productive of sputum and maybe even blood. And then fever and cough, rapid onset, sebentar saja panas dan batuknya. But the tuberculosis fever and cough have more longer period, more than 14 days. Yeah, 14 days. And shortness of breath early, COVID-19 early, shortness of breath. But the tuberculosis is later stage. Jadi kalau tuberculosis itu untuk sesak napasnya, kalau ada pasti ini pada kondisi yang sudah lanjut. Karena awalnya tidak sesak napas, beda dengan COVID-19, gejala awal pada 2 minggu awal itu sudah sesak napas. Testing specimen nasopharyngeal or oropharyngeal swab. But the tuberculosis is by sputum. Diagnosis test by real-time polymerase chain reaction, maybe rapid test, but it's not a recommendation. And then chest CT scan. Yeah. And tuberculosis chest radiograph, and then we go back to the culture or molecular technique, and also demonstration of acid-base bacil tahan asam. The pathology, COVID-19 endothelial damage and coagulopathy small vessel, discuss. Jadi bentuk-bentuk dari pembekuan darah sekarang problem yang sulit diatasi untuk COVID-19. Sedangkan tuberkulosis tidak ada ini koagulopati, tapi di sini adalah perkejuan, ya, nekrosis perkejuan atau pembentukan granuloma. Kemudian obatnya COVID-19 dominan is supportive, not antiviral. Antiviral is sampai saat ini belum ada antiviral yang recommendation. Tapi kalau tuberkulosis sudah jelas ada pasti, anti-tuberkulosis treatment sudah ada. Sudah terbukti bisa membunuh, 6 bulan sudah sembuh, kecuali ada resisten ya. Kemudian pencegahan, sebenarnya mirip kalau pencegahan. Self distancing sama, hand washing sama, pakai protective personal equipment juga, ini lebih advance mungkin ya dibanding tuberkulosis. Kalau tuberkulosis ya self distancing saya kira juga baik kalau kondisinya dia memang sedang aktif. Tapi pada tuberkulosis punya vaksin yang efektivitasnya untuk gejala TB berat yaitu BCG, Bacillus calmette-guerin, ini ada. Sedangkan COVID-19 sampai saat ini vaksin belum ada. Kemudian kesamaannya organ affected. Ini sama paru, tapi sebenarnya tadi sudah di depan saya sampaikan sebenarnya tidak hanya di paru, di luar paru pun ternyata berimbang juga. Ya. Kemudian genetic and non-genetic factor of knowledge of individual susceptibility ini ya diduga ya. Kemudian spread dengan close contact sama, ya. Cuma kalau yang COVID-19 ini agak sulit, ya. Tapi kalau TB pakai sputum BTA biasanya. Kemudian action strategi pada COVID-19 yang kita sebut tadi juga sudah disampaikan di presenter pertama, find, kemudian track trace test. Kalau terbukti positif, isolate and prevent strategi. Sebenarnya sama, di TB juga sama. Ya. Jadi TOS itu terapi obat sampai sembuh itu kan juga bagaimana men-tracer ya, atau mencari kasus kemudian ditelusur. Kemudian health system sama, semuanya menjadi beban, public awareness sama-sama dibutuhkan. Data sharing platform at national and international level masih lacking. Jadi di sini yang mungkin tadi underreporting itu saya kira di COVID-19 bisa juga underreporting juga. Karena kan berapa yang dites, tidak semua dites dan sebagainya, mungkin kasus real di lapangan lebih banyak, bisa saja. Mortality sama-sama tinggi. Ya. Ini tuberkulosis sebenarnya sudah lama di atas 1 juta per tahun, tapi sekarang sudah disalib oleh COVID-19 sudah 1,5 juta. Ya, tapi angkanya memang semuanya tinggi. Angka 1 juta, jumlah kematian 1 juta itu tentunya bukan angka yang kecil. Kemudian risk factor juga sama ini yang tercantum di sini ada elderly, diabetes, HIV dan sebagainya. Personal protection measure, basic infection prevention and control, sama ini, cough, etiquette, patient triage and washing, ya sama. Oke, kemudian memakai digital health teknologi saya kira juga penting di situ. Nah ini bahasa Indonesianya saja, ini saya kira sama dengan yang tadi. Kemudian bagaimana treatment co-infection? Tuberculosis treatment is no different in people with or without COVID-19 infection. Sama saja antara TB dengan COVID-19, TB tanpa COVID-19 sama. Patient on anti-TB drugs, ya, whether for latent TB, drug sensitive TB, or MDR TB, ya, should continue their treatment. Jadi pada kondisi apakah dia laten apakah dia TB yang saat ini sensitif ataupun yang MDR yang baru dipresentasi tadi, tetap saja continue their treatment uninterrupted even if they acquire COVID-19. Ini tujuannya to increase chance of cure and reduce transmission and development of drug resistance. Untuk drug interaction, experience and co-management of both COVID-19 infection and TB remains limited. Tidak banyak data-data yang menunjukkan bagaimana co-infection COVID-19 TB. Tentunya di sini adalah interaksi obat. Lopinavir, ritonavir ini adalah obat yang digunakan di COVID-19. A widely used antiretroviral drug combination. When used with rifampicin, lopinavir, ritonavir with rifampicin, there is a drug interaction which can potentially increase rifampicin level resulting in serious hepatotoxicity. Jadi rifampicin yang sebenarnya memang punya efek hepatotoksik, itu ada dosis yang aman, tapi ketika drug interaction with lopinavir and ritonavir, they can increase level and then resulting serious hepatotoxicity. Lopinavir, ritonavir also significantly increase the level of beta-quilin resulting in QTc prolongation and increased risk of cardiac arrhythmia. Lopinavir, ritonavir, obat di COVID-19. Kalau beta-quilin ini adalah obat MDR TB yang tadi juga disampaikan. Ini kalau sebenarnya beta-quilin itu bisa menyebabkan QT prolong atau gangguan aritmia pada jantung. Ini patologis pada jantung. Nah ini kalau dikombinasi bisa ini meningkatkan efek samping dari beta-quilin. Ya. Kemudian tentang the potential impact of COVID-19 pandemic on tuberculosis control. Impact of COVID-19 on household transmission of TB. Ini COVID-19 bisa meningkatkan penularan dalam rumah. Karena apa? They are advising of requiring people to stay at home. Nah, jadi kalau orang diminta untuk stay at home padahal dia TB, tentu akan meningkatkan penularan TB. Kalau orang tersebut memang berpenyakit TB. Impact of COVID-19 on TB treatment and diagnostic service. Ya, TB treatment kontrol pada pengobatan TB, pelayanan TB. TB harus akan biasanya kontrol 2 minggu sekali atau 1 bulan sekali. Ini dipastikan pasien tetap minum obat, tapi pada kondisi pasien yang takut ke rumah sakit ini memang harus mempunyai strategi ini. Desain mekanisme desain mechanism to deliver medicine and to collect specimen for follow-up testing at home. Kemudian yang ini saya kira penting, ini integrate TB and COVID-19 service for infection control, contact tracing, community care, surveillance, and jadi bisa saja program ini dipadukan tentang infection control, tentang contact tracing. Jadi kalau dia COVID-19 terutama kalau positif kan pasti ada contact tracing dari dinas kesehatan. Ini dibarengkan dengan TB. Jadi ketika kontak tracing orang, kita tanya juga gejala-gejala TB. Kalau ada, nah ini segera di sputum BTA ataupun TCM. Sehingga ya sekali sistem itu bisa dipakai dua. Provide short student and health professional and recruit additional staff to work on TB program. Nah ini kalau masalah-masalah ada tenaga kesehatan yang terkena TB, ya ini perlu rekrutmen. Change policy if required and support private and academic of research center to provide TB testing and treatment. Nah, ini untuk mengatasi penelitian yang berubah tadi. Use virtual care and digital technologies. For example, video observed therapy or adherence support, early initiation of treatment, remote monitoring of TB patient, counseling, and follow-up consultation. Kemudian tentang affecting TB prevention and control strategy. Organize virtual, virtual conference, virtual seminar, virtual workshop, and fundraising. Design strategy deliver immunization, BCG, and TB preventive therapy at home. Create community awareness and importance of TB service. Kemudian untuk reactivation of TB, plan additional support and resources. Burden of TB, conduct research to identify the impact of COVID-19 on reactivation of TB and to design intervention mitigating this problem. Nah ini kalau klinisi, barangkali audien ada dokter di sini, apabila ada pasien dengan batuk dan demam, ini tanyakan onset. Ini gejala ini penting karena kalau akut itu adalah COVID-19 mengarah ke dengan faktor risiko yang mengarah ke COVID-19. Di foto torak, darah periferi lengkap, swab, PCR. Ini. Tapi kalau gejalanya kronik, jadi batuk-batuknya dia sudah 1 bulan atau 2 bulan, berarti risiko mengarah TB. Itu foto torak juga sebenarnya sama, tapi perintahnya adalah sputum BTA. Biasanya foto torak ini akan mengikuti TB dan COVID-19 ini beda, foto toraknya beda. Nah, bagaimana kalau yang pasien TB? Jadi kalau dia datang ke UGD, tapi sebenarnya dia sudah sakit TB. Nah, kita kadang-kadang akan menduga apakah ini TB-nya yang memberat, jadi kasus TB saja yang memberat, ataukah TB dengan koinfeksi COVID-19. Nah, ini akan kita lihat gejalanya kalau demam lebih dari 38, ada kontak dengan kasus terkonfirmasi, satu rumah misalnya, kemudian sesak napas memberat, kemudian batuk muncul. Nah ini kemudian dilakukan dengan foto torak. Kemudian darah lengkap. Nah kemudian ini nanti kalau kasusnya ini mengarah ke COVID-19, lakukan pemeriksaan swab nasofaring, PCR ataupun TCM. Sedangkan apabila kasus ini tidak mengarah ke COVID-19, apakah infeksi TB resisten atau melanjutkan tata laksana TB. Jadi tetap saja pasien TB itu bisa kita pilih. Sebagai resume, the rapid spread of SARS-CoV-2 and the unprecedented nature of COVID-19 has demanded an urgency in both science and clinical research. And the scientific community has met that call with remarkable productivity. Second, TB treatment is no different in people with COVID-19 infection. Patients on anti-TB drug, whether for TB, should continue their treatment uninterrupted, even if they acquire COVID-19 to increase chance of cure and reduce transmission and development of drug resistance. Oke, thank you. Oke, kembali ke bicara. Ya.
Right, that's the wonderful presentation from Professor Dr. Reviono. Begitulah tadi kita dengarkan bersama pemaparan yang sangat luar biasa dari Profesor Dr. Reviono membahas tentang tuberculosis during COVID-19 pandemic. Baik, Prof, untuk mempertajam pemahaman kita terhadap materi yang disampaikan oleh Profesor Revi, kita akan langsung membuka sesi kedua, Prof. Kami persilahkan kepada partisipan webinar yang ada di sini maupun yang secara virtual untuk join atau bergabung dalam sesi tanya jawab ini. Kami persilahkan kepada Bapak Ibu yang di sini. Ada nggih? Monggo kami persilahkan Ibu.
Ya.
Prof Revi, Pak Moderator juga. Saya Noor Hidayah, Prof. Terkait sekali dengan penjelasan Prof terkait dengan COVID-19 dan mungkin tentang masih spesial gitu. Ini saya menanyakan dari yang pernah saya baca, baik COVID ya maupun TB itu bisa muncul kembali walaupun sudah di kemudian ya Prof, istilahnya untuk kondisi, terutama untuk yang kondisi itu kan sudah ditemukan tapi yang pernah dengar walaupun sudah dinyatakan sembuh dari TB, tapi jika seorang yang pernah terkena TB itu bisa mengalami TB, ya. Kemudian termasuk yang COVID juga, jika sudah dinyatakan sembuh dari hasil PCR sudah negatif, hasil rapidnya juga sudah negatif, tapi sewaktu-waktu juga akan muncul kembali. Non sewu, ini mohon penjelasannya, Prof. Oke, matur suwun. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam.
Baik, bisa langsung dijawab pertanyaan dari Ibu Noor Hidayah. Kami
persilakan. Terima kasih. Jadi benar tadi kalau kasus itu kita sudah sering yang namanya kasus. Kalau yang di program TB paham kasus kambuh itu sudah ada bukti. Sedangkan COVID-19 ini untuk kasus reinfection istilahnya ya masih dipakai reinfection ini jarang. Kalau ada kasus reinfection itu akan menjadi menarik, kemudian biasanya masih menjadi tulisan yang banyak akan tertarik membacanya. Saya pribadi tidak banyak, tapi di Solo itu sudah ada 1.000 mungkin ya kami rawat bersama dengan rekan-rekan itu, baru ada dua yang reinfection. Dan ini yang saya juga ketika baca di jurnal kalau di Taiwan juga, satunya di Cina, itu ada kasus reinfection, itu gejalanya lebih berat ternyata dibanding infeksi pertama. Itu termasuk yang ada di Solo ini, yang 2 itu ternyata lebih berat. Tapi alhamdulillah sembuh. Itu bukti-bukti. Kemudian kalau mengapanya ini kan yang jadi pertanyaan. Jadi ternyata kalau ini terjadi vaksinasi yang harus bisa menjawab. Jadi satu tubuh saja ini belum bisa, satu tubuh. Jadi kalau vaksin itu kan, kalau yang terjadi kasus TB sebenarnya dalam tubuh respon yang harusnya masuk semua, itu belum bisa mengatasi, masih ada terjadi reinfeksi. Gimana kalau sekedar vaksin, kan itu. Ini sebenarnya sama dengan kasus tuberkulosis. Dua kasus jadi satu jadi pembahasan. Ini bisa mencegah, tidak bisa mencegah atau efektivitas vaksin itu masih di bawah yang diberikan oleh WHO. Itu sebenarnya efektivitas vaksin itu 80% atau 70% masih direkomendasi oleh WHO. Jadi kalau 70% berarti 30% dia masih terkena TB. Tetapi kalau BCG itu bisa mencegah TB derajat berat. Memang bisa dibuktikan sebenarnya. Kalau yang TB derajat berat seperti meningitis TB atau TB yang sampai meninggal itu vaksin BCG-nya tidak bagus. Nah, nanti COVID-19 juga sekarang jadi tanda tanya. Vaksin ini sekarang sudah ada 11 vaksin di dunia, tapi di Indonesia 4 yang uji klinik. Uji klinik itu artinya masih dalam penelitian. Ini yang vaksin ini adalah orang rawan sebenarnya. Yang satu ada di Bandung yang dipegang oleh Unpad, kemudian satu lagi di Indonesia vaksin merah putih itu sedang masih belum uji klinis fase 3, tapi baru fase 2, tapi mau fase 3, Ekman dan Kementerian Ristek. Kemudian satu lagi yang di Jawa Timur itu vaksin dari Sanofi, dari Amerika. Nah, ini juga sedang uji klinis fase 3. Kemudian satu lagi M.Kes yang ini akan menggandeng UNS dan sampai saat ini kami akan ada dicoba di Jawa Tengah. Ya. Nanti itu akan ada 2 yang dinilai, efektivitas dan keamanan. Efektivitas yang saya 80% itu vaksin ini akan dipakai pasti, akan jadi program. Nah, ini Sinovac yang nanti akan laporan akhir Desember, apakah berapa efektivitasnya. Nah, kalau keamanan ini harus aman. Saya nggak tahu ukurannya, tapi harus aman. Kalau tidak aman mungkin selesai, walaupun efektif, tapi tidak aman akan tidak dipakai. Jadi, mungkin menjawab pertanyaan atau tidak? Ya, monggo.
Tadi pemaparan dari Profesor Dr. Reviono. Ada Ibu dari Hidayah nanya apakah sudah terjawab? Kira-kira sampun nggih. Kita akan lanjutkan ke pertanyaan kedua. Kami persilahkan kepada peserta webinar internasional hari ini ataupun para peserta yang ada di ruang ini untuk berpartisipasi dalam sesi tanya jawab. Kami persilahkan jika ada. Ada dari chatroom? Tidak ada. Bapak Ibu, kami persilahkan satu pertanyaan lagi jika ada untuk berpartisipasi dalam tanya jawab ini. Ini Prof, mungkin ada pertanyaan dari chatroom, coba saya bacakan. How can we prevent the mortality of TB sufferer who are infected with COVID-19? In some cases, who are infected with COVID-19. Prof, seperti itu Prof pertanyaannya.
Ya, jadi ya ini kalau COVID-19 saja tanpa TB pun sebenarnya tergantung pada respon imun kita, apakah dia normal, apakah berlebihan. Jadi TB ini sebenarnya, ini kan mencegah, pertanyaannya kan mencegah kematian TB kan. Jadi dia sakit TB kemudian tertular oleh COVID-19, kan? Pertanyaan seperti itu. Jadi kalau pasien sudah terkena TB, dan dia terkena penyakit akut yang disebut COVID-19. Nah, COVID ini tergantung dari respon tubuh tadi. Ya, memang kalau TB-nya ini adalah TB yang ringan, itu kita bisa menduga bahwa respon imunnya itu normal. Jadi kemungkinan COVID-19 juga akan direspon secara normal. Jadi peluang sembuhnya lebih tinggi. Tapi kalau TB-nya itu berat, apa itu? Kalau memang gejalanya berat, ini berarti berisiko bisa mengenai ada riwayat berat, kan, berisiko untuk terjadi kematian. Di imun. Seperti itu.
Demikian tadi pemaparan penjelasan jawaban atas pertanyaan yang kedua kepada siapapun yang sudah terjawab. Selanjutnya masih ada satu kali lagi, kami persilahkan jika ada. Belum ada pertanyaan? Tidak ada? Di sini? Disampaikan? Ada? Kalau tidak ada, mungkin sudah. Baik, Prof. Mungkin untuk sesi kali ini kami kasih apresiasi kepada Profesor Reviono. Sekali lagi beri tepuk tangan yang meriah kepada Profesor Reviono atas biasa. Ini mungkin ada closing statement sebentar dari Prof Reviono. Kami persilahkan.
Baik, kalau untuk COVID-19 kita ikuti petunjuk dari tentang 3M supaya tetap dilaksanakan, supaya insiden dari COVID-19 tidak meningkat. Dan di samping itu, dengan program 3M ini tentunya bisa mencegah penularan dari tuberkulosis. Tapi ingat, bagi yang saudaranya ada yang menderita tuberkulosis, agar program pengobatan itu tetap terjaga, bisa tetap bekerja. Oke.
Pemaparannya sekali lagi beri tepuk tangan yang meriah untuk Prof. Reviono. Ini akhiri sesi yang keempat ini. Terima kasih, Prof. Salam keluarga di rumah, dan ini akan lanjut ke sesi berikutnya, yaitu sesi yang kelima, sesi terakhir. Before I continue the last session, I would like to say once again, thank you to Taiwan International Healthcare Training Center for supporting this conference, this webinar conference. And this virtual conference is held in the agenda of 21st anniversary of Muhammadiyah University of Kudus. Okay, now we will go directly to the last session, session 5, a presentation delivered by Dr. Haji Edy Wuryanto. Right, so let me keep in touch with Dr. Edy Wuryanto. Have you been connected with us, sir? Bapak Edy, apakah sudah terhubung dengan kami? Assalamualaikum warahmatullahi wabarakatuh. Bapak Edy, have you been connected with us? Hello? Sudah bisa mendengar suara saya, Bapak? Sampun?
Assalamualaikum Mas.
Oh ya, baik. Nah, baik.
Moderator yang ganteng.
Baik, sudah terhubung ya. Baik, bersama kita sudah ada narasumber yang terakhir. Nah, but before the presentation is done, we will have a photo session together. Kita akan foto sesi dulu bersama-sama untuk dokumentasi. Right, I invite all participants here to join the photo session, please. Kami persilakan kepada para peserta webinar untuk bisa berfoto bersama dengan Bapak Edy sebelum beliau memaparkan materinya. Oke. One, two, three. Again, one, two, three. Freestyle, freestyle. One, two, three. One, two, three. Sesi disampaikan oleh S.Kp.M. Before we do his full name is Edy Wuryanto. His education in 1990 developed nursing Muhammadiyah, then degree of nursing in Universitas Indonesia. Degree or PhD degree in Gajah Mada University. About his career, now he is a civil servant. Seperti sebelumnya 6 jateng di Universitas Sebelas. He is also a dean of Faculty Ilmu Keperawatan dan Kesehatan Universitas Muhammadiyah Semarang tahun 2003 sampai 2004, and then he is also Vice Rector of Universitas Muhammadiyah Semarang 2004 sampai 2012. And then about his organizational background, sekarang menjabat sebagai Ketua Asosiasi Perguruan Tinggi Kesehatan Swasta Jawa Tengah 2 periode 2009 sampai dengan 2019, Sekretaris Jawa Tengah 2005 sampai 2010, Ketua Persatuan Perawat Nasional Indonesia PPNI Jawa Tengah 2 periode juga, Pengurus Persatuan Indonesia RC Jawa Tengah 2017 sampai 2022, Ketua Organisasi dan Kelembagaan AIPNI Pusat 2017 sampai 2001. Selanjutnya sosial dan pengurus 2004 sampai 2008 dan 2014 sampai 2019. Beliau juga menjabat sebagai Ketua Petani Jambu Air Kabupaten Reviono. Menarik sekali, beliau banyak sekali kiprahnya di bidangnya, dan terakhir di bidang politik sekarang beliau menjabat sebagai Komisi RI tahun 2009. Beliau, nah, itulah tadi kurikulum vitae dari beliau. Silahkan beliau langsung bisa Pak Edy Wuryanto. The floor is yours.
Warahmatullahi wabarakatuh. Selamat siang, salam semua. Moderatornya ini siapa ya?
Nama saya Ahmad Nur Syafiq, Bapak. Syafiq G.
Oke, terima kasih Mas Syafiq. The Honorable, my best friend, Rector Muhammadiyah of Kudus, Tuberculosis General Hospital Taiwan, Profesor Dr. Reviono, spesialis konsultan Rector Universitas. Terima kasih. Tapi izinkan saya mewakili teman-teman dan pembicaraan dari izinkan saya share screen. Saya mohon maaf tidak sempat untuk mentranslate dalam bahasa Inggris, tapi intinya peran DPR dalam pengembangan nasional, khususnya untuk penanganan COVID-19 dan TB paru. Dua-duanya ini sekarang sedang jadi fokus di Komisi 9. Jadi kami ada mitra Menteri Kesehatan, BPJS Kesehatan, yang terkait dengan kesehatan ada obat dan makanan, PKKBN. Nah, M.Kes, BPJS Kesehatan, dan Badan POM ini banyak terlibat di COVID. Terakhir ini Badan POM untuk menjamin vaksin yang masuk ke Indonesia ini harus aman dan efisien. Kalau M.Kes jelas sejak awal penanganan COVID ini menjadi leading sektor terutama di bidang kesehatan. Kerja Badan Perlindungan Pekerja Migran Indonesia ini juga kementerian yang dengan tenaga kerja. Kita tahu COVID tidak hanya berdampak pada kesehatan, juga berdampak kepada ekonomi dan tenaga kerja. Sudah 29 juta dampak COVID, dan itu harus diselesaikan oleh negara. 700 triliun uang kita habis di COVID dan tenaga kerja, dan sebagian besar itu bukan kesehatan. Kalau kesehatan sih hanya sekitar 90 triliun, tapi yang lebih banyak itu untuk menopang hidup rakyat yang bekerja menjadi tidak bekerja, yang semula usaha menjadi tidak punya usaha, kita support agar tidak terjadi resesi. Maka Komisi 9 sejak COVID ini melanda Indonesia, dan policy pemerintah dan regulasi pemerintah itu tepat sesuai dengan situasi dan kondisi Indonesia. Tugas kami ada 3, politik regulasi, mengatur dengan regulasi, yang politik anggaran, membagi uang agar semuanya tercover, dan yang terakhir mengawasi apakah 7 mitra ini telah bekerja sesuai dengan kesepakatan dengan. Nah, tugas ini pada era COVID ini betul-betul ekstra, karena kalau kita tidak bisa keluar dari selatan, maka tentunya akan berdampak kepada negara yang kalang kabut, yang juga terdampak berat karena yang tidak tepat di dalam penanganan COVID. Agak sedikit meluaskan aman kita itu utuh. Kita masih punya persoalan ini, angka kematian ibu dan bayi juga ada dampak dari COVID. Kita masih punya persoalan stunting yang ini menjadi prioritas nasional Pak Jokowi, karena indikator SDM, sedangkan SDM merupakan Pak Presiden. Imunisasi sudah lumayan. Epidemiologi ke penyakit tidak menular, ini yang menghabiskan uang negara. Penyakit banyak dana di BPJS, yang tata kelolanya harus kita perbaiki. Ini contoh beban penyakit tidak menular, jantung, stroke, ginjal, diabetes, kanker, thalassemia, hemofili. Ya, ini menghabiskan betul bagian dana BPJS, dan yang membuat persoalan kalau tidak kita ubah BPJS kita akan sulit. Sejak awal sebelum COVID kita memang menurunkan TBC di Indonesia, karena TBC ini Indonesia peringkat ketiga dunia, yang tentu harus mendapat. Nah, sejak dulu penanganan TBC di Indonesia dinilai tidak efektif dan tidak efisien. Sudah berapa dana bantuan dunia yang masuk ke Indonesia agar TBC ini sudah angkanya turun, tapi tidak segera turun, tapi malah cenderung naik. Bahkan di era COVID ini diduga insidensi TBC di Indonesia. Maka seminar hari ini menjadi tepat ketika mengkaitkan antara COVID-19 dengan TBC. Infrastruktur kesehatan kita belum kuat, dan itu tampak kesiapan kita dalam penanganan COVID. Karena itu infrastruktur kesehatan kita itu menjadi sorotan Komisi 9 dan DPR RI. Itu menyangkut berbagai hal, karena di samping kita sudah masuk ke universal health coverage, tapi dari ternyata persoalan mendasar yang kita hadapi, infrastruktur kesehatan kita tidak cukup kuat, termasuk ketika kita kelabaan pada fase awal penanganan COVID. SDM kesehatan kita juga belum merata, terutama dokter dan dokter spesialis. Wilayah timur itu ketika ingin mendirikan layanan kesehatan selalu kekurangan dokter spesialis banyak numpuk di kota besar, dan itu menimbulkan distribusi layanan kesehatan kita itu berpusat di Jawa dan Sumatera, dan itu berdampak pada putaran uang BPJS yang juga banyak di Jawa dan Sumatera. Wilayah timur ini kemudian menimbulkan ketidakadilan sosial di dalam sistem. Anggaran APBN kesehatan hanya 5%, itu termasuk kecil jika dibandingkan negara lain. Ditambah lagi 5% termasuk belanja pegawai dan support PBI, BPJS, yang menjadi tanggungan negara. Jadi dengan kondisi 5% APBN, ini sungguh sangat berat. Maka ketika ini berlangsung, kami gunakan momentum ini untuk menaikkan anggaran APBN kita menjadi 6,2%. Kemudian kenaikan anggaran 6,2% itu bisa memperkuat infrastruktur kesehatan kita sehingga kompetitif sesuai dengan persoalan kesehatan yang kita hadapi. ini masih dibanding dengan negara anggota ASEAN, kita masih kalah anggaran kesehatan kita. Nah, JKN terus kita perbaiki, jaminan kesehatan nasional, karena banyak persoalan di JKN kita yang belum seperti dituntut dalam prinsip-prinsip universal health coverage. Yang terjadi, JKN kita itu terlalu hospital, terlalu paradigmanya sakit, kurang pada upaya promotif dan preventif, lalu terlalu banyak untuk backup penyakit katastrofik, padahal ini penyakit advance yang hanya dinikmati, tapi kurang support di dalam memenuhi kebutuhan dasar kesehatan rakyat. Maka kita lakukan evaluasi terus-menerus pada JKN kita dan sistem BPJS agar lebih memperkuat basis-basis layanan kebutuhan kesehatan dasar dan menyentuh primary healthcare, dan lebih banyak orang-orang miskin yang lebih menggunakan manfaat BPJS. Oleh karena itu, di dalam 3 dimensi coverage, with service coverage, proportion of the cost coverage ini harus seimbang. With coverage 4% rakyat Indonesia menjadi anggota BPJS, dan 64% dari peserta BPJS itu adalah orang miskin dan ditanggung oleh negara. Jadi Indonesia itu termasuk negara yang berani mengcover orang miskin yang demikian besar jumlahnya, lebih dari 130 juta penduduk ketika mereka sakit itu menjadi tanggungan negara. Maka komitmen negara terhadap kesehatan rakyatnya itu sesungguhnya makin tahun makin meningkat. With service coverage lebih diarahkan pada kebutuhan kesehatan dasar. Penyakit-penyakit advance, katastrofik yang mahal, yang selama ini banyak dinikmati oleh orang menengah ke atas, mulai kita kurangi, lalu kita geser pada primary healthcare, pada puskesmas, pada klinik, agar sakit itu menikmati manfaat menjadi peserta BPJS. Nah, proportion of the cost coverage ini memang terkait dengan biaya. Nah, biaya iuran BPJS di Indonesia itu paling murah di dunia. 25.500 ini tergolong paling murah jika saya bandingkan dengan sebenarnya yang per bulannya kalau dirupiahkan itu 1,5 juta per bulan. Nah, ada persoalan mendasar di dalam JKN terkait dengan situasi ekonomi. Tax ratio kita itu kecil, dana masyarakatnya banyak. Akibatnya apa? Sektor kesehatan tertumpu pada APBN yang lemah. 64% peserta BPJS itu ditanggung oleh negara. Jadi sektor ini lemah, karena itu BPJS menanggung APBN, sementara APBN kita lemah. Maka ketika ada kenaikan iuran BPJS, mesti ada tarik ulur antara pemerintah dan rakyat. Ini tidak mau naik. Inginnya menaikkan karena betul-betul setiap defisit BPJS itu mengganggu APBN. Kan Pak Sri Mulyani dengan Komisi 9 ini selalu nggak klop, karena Komisi 9 rakyatnya, sementara Sri Mulyani Menteri Keuangan harus mempertimbangkan seimbang APBN agar defisit BPJS itu berdampak pada APBN. Dengan kata lain, pertumbuhan ekonomi di Indonesia dimanfaatkan oleh sektor yang bukan kesehatan. Ini sesungguhnya situasi yang tidak baik, maka selalu defisit total BPJS semakin besar, dan itu menjadi tanggung jawab APBN yang lemah. APBD tidak banyak menanggung defisit, lalu masyarakat mampu tidak menanggung. Dan ini yang tiga persoalan ini yang sedang kita perbaiki, mudah-mudahan ke depan. Ini terlalu teknis. Nah, ini yang muncul akhirnya, yang warna biru tua itu menunjukkan klaim BPJS-nya besar, sementara yang warna biru muda transparan itu wilayah-wilayah yang klaim BPJS-nya rendah. Dan Anda amati, misalnya di situ kasih contoh, orang NTT dengan orang Semarang sakit jantung. Kalau orang NTT sakit jantung, operasi, dia mau lari kemana? Akhirnya nggak bisa memanfaatkan BPJS. Tapi kalau orang Semarang sakit jantung, dia bisa ke rumah sakit karena maka dengan kata lain, lebih nikmat orang Jawa dibanding orang NTT, padahal sama-sama BPJS. Orang NTT mungkin lebih kaya, maka orang menikmati BPJS itu sesungguhnya yang ada di Jawa, Sumatera, yang relatif mampu dibanding orang NTT atau wilayah-wilayah gunung lainnya. Inilah yang menimbulkan keadilan sosial. Nah, ini yang kita perbaiki. Nah, kami sedang kenceng-kencengnya membahas itu, COVID melanda. Ya, ini ujian negara, maka mengubah semua. Awal-awal kita agak merespon lambat itu, termasuk beberapa pejabat pemerintah itu. Tapi kemudian akhirnya kita menyadari bahwa COVID ini persoalan yang kompleks, yang multi variabel, lalu dampaknya juga luar biasa. Tetapi ya kita harus sedikit berbesar hati, meskipun COVID di Indonesia meningkat, nggak pernah turun, tapi peningkatannya itu terkontrol dibanding negara lain. Ya, negara maju sekalipun sekarang yang kalau bisa menekan COVID, tapi begitu pergerakan penduduknya dilonggarkan, COVID-nya naik lagi. Begitu semakin dilonggarkan, muncul gelombang kedua COVID. Ya, Indonesia agak terlalu ketat, tetapi menjaga keseimbangan antara kesehatan dan ekonomi. Nah, kita agak longgar karena agak berbesar hati karena kasus sembuhnya 83,71% dibanding dengan angka globalnya 69,17%. Artinya COVID di Indonesia itu tingkatnya lebih tinggi kasus global. Bahkan dengan Amerika sekalipun, di Amerika itu tingkat kesembuhannya hanya 59,25%. Jepang misalnya, angka kesembuhannya 84,79%, lebih tinggi sedikit dari Indonesia. Angka kematian kita juga nggak terlalu tinggi, case fatality rate-nya itu 3,11%. Dengan global memang lebih tinggi, 3,4%. Ya kalau kita bandingkan Jepang, memang kita lebih tinggi, demikian juga Amerika. Tapi juga nggak terlalu mencolok. Maka karena ini WHO mengakui bahwa ada penanganan yang spesial COVID di Indonesia, lalu M.Kes diundang oleh WHO untuk presentasi ke seluruh dunia. Bagaimana sistem penanganan COVID di Indonesia? Kita tergopoh-gopoh, tapi dunia mengakui bahwa ada penanganan COVID di Indonesia. Kita lihat angka sembuh dan angka matinya. Sehingga sering saya katakan kepada teman-teman, kalau Anda kena COVID, Anda nggak punya comorbid, ya sebetulnya daya tahan tubuh Anda bagus, maka peluang Anda untuk sembuh tinggi. Ini yang mungkin variabelnya, mungkin juga kelembapan udara, suhu lingkungan, dan lain-lain, ya ini menjadi faktor variabel yang di Indonesia ini penanganan COVID lebih baik. Nah, bicara hari ini, tuberkulosis paru, memang COVID ini sebetulnya sudah awal ini pengen perang sama tuberkulosis paru. Nah, kemudian pandemik melanda dan ini dua-duanya menyerang sistem pernapasan, maka meningkatnya COVID, meningkat TBC. Orang yang TBC tentu punya resiko yang lebih fatal. Maka dua-duanya ini serius di COVID-19, termasuk juga demam berdarah. Karena beberapa wilayah dengan fokus pada pandemi COVID, ternyata demam berdarah juga naik. Nah, demikian juga kita terlalu fokus pada pandemi COVID, mengabaikan atau kita agak lengah terhadap TB paru, maka bisa diprediksi TB paru di Indonesia akan semakin meningkat. Ini saya kira beberapa data yang bisa dibaca sendiri. Ya, ini saya kira data dunia bisa dibaca sendiri nanti. Nah, COVID ini virus menyerang sistem pernafasan. TB juga dari kronis menyerang sistem pernafasan. Kalau dua-duanya maka mempengaruhi sistem pernafasan, terutama paru. Ya, paru kita rusak, COVID maupun TB. Orang yang TB menderita COVID sungguh memiliki resiko yang berbahaya, sehingga harus ada penanganan pasien TB jangan sampai dia terpapar COVID. Gejalanya hampir sama, batuk, panas, kesulitan bernafas. Ini irisannya. Ya. Mungkin tadi sudah disampaikan oleh Prof bahwa dampak COVID terhadap TB. Ya. Ternyata misalnya 3 bulan lockdown di India meningkatkan jumlah kasus juta. Ya. Angka kematian 438. Artinya apa di sini? Meningkatnya COVID juga diikuti dengan meningkatnya kasus dan angka kematian TB. Yang kedua, health service and political leadership, the media and the public focusing on pandemic management and respond with limited oversight and accountability of TB program. Ya ini, karena kita ini, ya siapa sih yang tidak fokus pada COVID? Saya kira kalau negara lengah sedikit terhadap COVID saja, respon publiknya luar biasa. Dan disoroti karena akhir ini peningkatan kasus di Jawa Tengah demikian cepat, demikian tinggi. Nah ini seringkali limited oversight and accountability of TB program. Ini kita dianggap ya ini yang menjadi perhatian serius. Affecting TB prevention and control strategies, ya tadi sudah disampaikan ya bahwa akibat COVID ini anggaran terseret ke situ, semua fokus terseret ke situ, layanan kesehatan terseret ke situ, maka ini mempengaruhi tahun 2035 yang kita harapkan global strategi dan penanganan berakhir ya kita mungkin agak mundur itu dari 2035. Yang terakhir reaction of TB, pneumonia, respiratory failure caused by COVID-19 may cause long-lasting damage to the respiratory system, particularly the lung, which might increase the risk of TB. Ya ini tadi saya kira ternyata karena dari sisi klinikal saya kira yang disampaikan Prof tadi sudah benar. Strategi untuk mengurangi dampak sampaikan itu. Ini hanya mengulang saya kira. Karena ini bukan tugas saya dari government, bagian dari pemerintah, tapi tidak apa-apa untuk review saja. Nah ini strategi of COVID-19 on TB control tadi sudah disampaikan satu persatu secara detail tadi. Oleh Prof tadi saya lihat materi terakhir. Maintain support to essential TB services during and after the COVID-19 pandemic. Ya, tetap kita harus support layanan TB, ya, pada pasien tentang COVID dan TB, sehingga mereka memperoleh pemahaman yang lengkap ketika dia menderita TB. Saat COVID itu harus bagaimana, pasien yang TB itu ketika merespon terhadap COVID ini bagaimana. Yang penting harus ada isolasi, harus ada penanganan khusus pada pasien TB, jangan sampai terproteksi betul, jangan sampai dia kena TB. Saya kira nanti bisa dibaca sendiri. Ini strategi untuk ya saya kira hampir sama tadi yang disampaikan Prof. Usulan dapat dipertimbangkan untuk 30 dan 25 ini bisa dibaca sendiri terkena COVID. Lalu kegiatan yang dipertimbangkan di masa COVID, ini saya kira nanti juga sudah disampaikan tadi banyak, termasuk juga multi-sectoral accountability framework for TB, komitmen, reporting, review. Saya kira semua pemangku kepentingan juga harus berpartisipasi. Nah, Komisi 9, kami telah bekerja keras di dalam merespon COVID. Bahkan kami ya hari-hari Covid-19 itu semua tamu, semua stakeholder, semua mitra itu diarahkan pada penanganan COVID. Anggaran ya, bahkan dulu kita sempat intensif itu mengusulkan tentang sistem kesehatan karena selama ini undang-undang kita itu terlalu banyak, kurang mengarah kepada konstruksi bagaimana negara ini mengatur tentang kesehatan nasional. Maka sistem kesehatan nasional yang dulu baru peraturan presiden kita sudah naikkan menjadi undang-undang, pemikirannya menggunakan metode omnibus law, karena undang-undang kesehatan itu banyak sekali, kita mau merevisi semua nggak mungkin, waktunya terlalu lama, sedangkan kalau kita ingin cepat ya semua undang-undang di bidang kesehatan itu kita review menjadi undang-undang sistem kesehatan nasional, maka sistem ini kita sebut dengan metode omnibus law. Ya, paradigmanya kita harapkan menjadi paradigma sehat, bukan paradigma sakit. Lalu beberapa item tentang upaya kesehatan, pembiayaan kesehatan, SDM kesehatan, manajemen informasi dan regulasi kesehatan, penelitian dan kesehatan, farmasi, alkes, pembelian ini menjadi poin-poin penting dalam RUU Kesehatan Nasional agar ada perubahan di dalam paradigma kesehatan di Indonesia. Termasuk ini, ya ini DPR RI, lah termasuk juga agenda reformasi sistem kesehatan nasional ada 8, baik meliputi pendidikan dan tenaga kesehatan, penguatan puskesmas, peningkatan rumah sakit yang di DTPK, kemandirian farmasi dan alkes, ketahanan kesehatan atau health security, pengendalian penyakit kesehatan, teknologi informasi dan pemberdayaan masyarakat. 8 item ini menjadi pokok-pokok penting antara Menteri Kesehatan dengan Komisi 9 yang dikawal baik, terutama yang nomor 2 terkait dengan apa ini puskesmas itu kalau bisa wall ya, tenaga kesehatan yang lebih masyarakat door to door, di situ ada TB, rumahnya ditandai, lalu penanganannya bagaimana, obat-obatnya disediakan yang apalagi di masa COVID, jangan sampai pasiennya yang banyak keluar, tapi nakesnya yang menyediakan obatnya sampai level keluarga dan seterusnya. Ini berarti membutuhkan peran revolusi fungsi puskesmas lebih banyak pada upaya kesehatan masyarakat dibanding selain upaya kesehatan perorangan yang selama ini agak terabaikan UKM kita, lalu mendorong upaya promotif preventif selain upaya rehabilitatif. Nah ini kita harus mengevaluasi mengapa TBC kita nggak turun, karena memang pemberdayaan masyarakat kurang, peran serta masyarakat kurang, masyarakat oleh tenaga kesehatan kurang, karena sistem kesehatan kita selama masih terlalu berfokus pada hospital atau hospital oriented. Anggaran kesehatan sudah kita naik sekarang 2%, saya harapannya sih sekitar 7,5%, sehingga kesehatan kita itu tambah dan membuka keran untuk pembiayaan, terutama yang orang mampu, yang kaya, itu harus diberi peluang untuk bayar iur. Nah, ini mendesak pengaruh utamaan anggaran promosi di Komisi 9, dan tampaknya kawan ini juga mengikuti semua yang diperintahkan oleh Komisi 9. Revitalisasi fungsi. Dulu kan bangga kalau puskesmas itu rawat inap. Karena dari posisi itu uang yang mengalir di BPJS itu nggak lari kemana-mana. Bupati sering menjadikan puskesmas rawat ini jadi sumber PAD. Akibatnya ya berputar pada layanan yang bersifat kuratif, lalu yang promotif preventif UKM terabaikan. Ini yang nggak boleh. Maka, dengan JKN hasil kita itu pondasinya untuk kesehatan dasar dan layanan kesehatan yang bisa melayani kebutuhan dasar kesehatan itu yang lebih diutamakan. 3 hari yang lalu kami rapat dengan BPJS jam 10 malam untuk mencoba mencari solusi agar BPJS itu diarahkan untuk kebutuhan kesehatan dasar yang itu menjadi kuasa. Ini anggaran COVID saya kira sudah semua paham. Nah, ini kita lihat yang memang kesehatan agak rendah, semua pengembangan. Nah, peran DPR dalam penanganan COVID sudah demikian banyak, seringkali ya itu nggak tersampaikan di publik, tapi kami rapat sampai subuh untuk mengawal agar penanganan COVID bisa lebih baik. Yang terakhir, untuk khusus TB paru Agustus 2020, ya, tambahan anggaran penanggulangan dan tuberkulosis Kementerian Kesehatan 2020 itu kita tambahkan total 2,9 triliun. Kami agar COVID, tuberkulosis, hepatitis itu naik. Misalnya di situ untuk insentif tenaga medik kita tambahkan 1,4 triliun. Jadi keluhan tenaga medik yang kurang itu kita juga sampaikan ke Banggar, ke Menteri Keuangan, kita naik 1,4 triliun. Tenaga PPDS juga 1,1 triliun, hepatitis 82 miliar, lalu untuk tuberkulosis 311 M. Ini bentuk komitmen kami di dalam. Terima kasih. Assalamualaikum warahmatullahi wabarakatuh.
Tadi yang luar biasa dari beliau Bapak Dr. Haji Edy Bapak Edy. Ya, terakhir ini sangat sekali semua peserta webinar, baik untuk mempertajam pemahaman tentang pemaparan materi yang disampaikan oleh Bapak Edy, untuk bisa bertanya sesi diskusi. Kami akan sesi tanya jawab Bapak setelah ini. Baik, kami persilahkan kepada peserta, kami persilahkan untuk bertanya chatroom maupun yang ada di ruangan ini, kami persilahkan. Ada? Kami persilahkan. Ya, akan memperkenalkan sebelum.
Assalamualaikum. Biasa cukup tinggi sekali. Bagaimana dari Komisi 9 ini kasus pandemi COVID ini, saya ini. Nah, kebetulan khusus area yang terima kasih.
Baik, Pak Edy Wuryanto memberikan penjelasan.
Setuju bahwa di mulai melonggarkan, diharapkan dengan masalah alternatif itu yang tepat. Negara ini kan ini menjadi perhatian serius, menyampaikan kepada khusus yang kurang dari wali kota, setiap yang terhadap ini turun. Patuh terhadap kesehatan ya. Masuk fokus pada pilkada. Kalau orang pada pilkada, penanganan COVID-nya lemah. Bahwa ini meningkatkan COVID. Pilkada dan politik tapi konsentrasi daerah menangani COVID negatif itu semua yang kita lakukan. Nah, tugas masih makanya juga. Nah ini maka satu jalan semua harus kesehatan protokol kesehatan tahu banyak kesulitan di lapangan. Tapi kewaspadaan itu harus kita keterbatasan yang ada. Saya Mas.
Seperti itu penjelasan dari Bapak Edy Wuryanto. Kepada penanya, apakah sudah bisa terjawab pertanyaannya? Baik, sudah ya. Kami lanjutkan dengan pertanyaan berikutnya. Kami persilahkan Bapak Ibu di sini atau melalui aplikasi Zoom yang ingin bertanya. Kami persilahkan. Tidak ada? Ibu, Bapak yang ada di sini? Sudah cukup? Saya kira sudah tidak ada pertanyaan lagi. Materinya sudah bisa di.
Oke, thank you ya waktunya ya.
Bapak tetap untuk memberikan sedikit statement closing kepada kami.
Selamat pada Kudus. Panglima yang baik sehingga signifikan terhadap perkembangan tinggi upaya promosi masyarakat ini harus kesehatan, maka persoalan kesehatan proses yang tepat, kos biaya kesehatan yang lebih diarahkan pada primary healthcare dan upaya penting di dalam nasional itu.
Terima kasih sekali Bapak atas.
Selalu saya izin ya.
Amin. Bapak. Bapak untuk apresiasi.
Kita sebelum dokter yang nanti diketahui yang lain. Ya harus segera dokter. Signifikan pada universitinya. Ya.
Assalamualaikum warahmatullahi wabarakatuh. So, ladies and gentlemen, I close. And we will thank you very much.
Okay, thank you, Mr. Syafiq. Ladies and gentlemen, bil alam.
Assalamualaikum warahmatullahi wabarakatuh.